Good evening, everyone. Happy Sunday to all of you. Yesterday, we started off talking about largely surgical aspects because I'd been told by Bhargav and by Sri Harsha and the organizers that this would be a group of predominantly surgeons. So we wanted to start off things basic. Today, it'll be a little bit more of recent advances, trying to get you to kind of experience how contemporary management of differentiated thyroid cancer is. Yesterday, our talks on thyroid nodule and on other aspects of management were pretty broad based. Today, we will take it a little bit further and talk about what to do after the initial thyroidectomy has been done. Subsequent to that, we'll have a vignette on recurrent nodal disease and how we manage it. And that's a surgical topic, of course. We'll define how uh, you define safe limits of redo central compartment surgery. A lot of you are already quite advanced into your practice, and you will be doing these, of course, in a country like India where practices are more heterogeneous. And then, of course, as Bhargav pointed out, we'll be talking about recent advances as we go ahead. So, with this background, let's move forward. Great. Bhargav, the slide is displaying properly for all of you, right?
Yes, sir. It's visible.
Okay, great. So let's talk in terms of case vignettes. This is a patient who presented to us a 30-year-old female with globus, and she has a left thyroid lobe incidentaloma on an ultrasound. And this is starting off where we left off yesterday. How do we apply practical knowledge gained by surgery in deciding what we have to do subsequently? So it's a TARAS 4 Bethesda 4 nodule. We talked to the patient about both options and we discussed that yesterday. The patient elected a hemithyroidectomy. Intraoperatively, there were no other nodules, anatomical landmarks were not distorted. The patient did well and was discharged in the outpatient setting. You see the specimen here. The final path is follicle FVPTC, 7 millimeters. And of course, we followed this patient with the serum thyroglobulin. So starting off, this is an ATA, or by all definitions, by all staging systems, a low-risk thyroid cancer. Remember that the guidelines for low-risk thyroid cancer have been modified over time, but this is the algorithm that you typically follow. And in this, we are incorporating the tenets of dynamic risk stratification also. And we'll keep on talking about that in the Q&A session also. When you do a lobectomy for low-risk thyroid cancer, remember, you're only doing a lobectomy for low risk. You consider a post-operative serum thyroglobulin. We normally like to get it at about 3 weeks in total thyroidectomy and between 2 to 6 weeks in a lobectomy. You do a neck ultrasound for follow-up at about 6 to 12 monthly intervals. In this case, there is no recommendation for remnant ablation, and the TSH goal is low. So for all practical purposes, this patient is treated. So the important thing to start off with when you talk about adjuvant therapy is to talk about the cases which do not need adjuvant therapy. Remember, we are talking about the currently prevailing paradigm shift. Not all thyroid cancer patients get a total thyroidectomy and adjuvant RAI. A significant minority, or I would say close to 30 to 40% of patients do not need RAI in our setting, even though we are seeing more advanced cancers. Moving on, we talked about low risk. This is a step up the notch, and we're using some cases to define how you decide your adjuvant therapy. This is a patient who had a FLUS, a Bethesda 3 on FNA, large lesion. Most of you would consider taking it out. So this discussion would not really be as much about surgical options as about the options in terms of extent of surgery. Yesterday, we talked about the fact that Bethesda 3, 4, and 5 nodules, more than 4 centimeter, would typically be offered a total thyroidectomy. Again, it depends on your institutional preference. This was a 7 by 6 centimeter nodule with an FNA indicating Bethesda 3. So we chose total thyroidectomy because of compressive symptomatology and radiological suspicion. The final pathology, as can be anticipated in a significant proportion of these patients, is a follicular thyroid carcinoma with extrathyroidal extension but focally present. Remember, focal extrathyroidal extension or minimal extrathyroidal extension is typically considered intermediate risk. It's not gross ETE. And there was minor capsular breach. And that, of course, remember that when you do these patients, you don't really want these patients to have significant capsular breach because that will really impede the pathologist in terms of deciding that. So contrary to low risk thyroid cancer, we are now talking about intermediate risk. Okay. So after a total thyroidectomy, where no central compartment clearance and no lateral clearance has been done, you evaluate your post-operative disease status again. This is the kind of patient in which we'll do a 3-weekly post-operative thyroglobulin. and you might consider other tests. Remember, at our setting or in our center, we would do a 3 weekly thyroglobulin. If the thyroglobulin is less than 1, stimulated with the TSH of more than 30, we would typically follow this patient. Also, because this patient is in the initial category of intermediate risk. You evaluate your response to therapy, and in case you've not chosen radioactive iodine scanning in the initial setting, you will follow these patients with a thyroglobulin as well as a neck ultrasound, moving down the algorithm. Applying dynamic risk stratification at 9 to 12 months, if the patient is an excellent responder, the patient does not need any intervention with the radioactive iodine scanning. However, if you're on the right side of the curve, if there is a BI, an SI, or an indeterminate response, then in that case, the whole algorithm changes. So remember, the patient's initial risk stratification is important, but with dynamic risk stratification, you can consider selective application in a subset of patients. And I'll tell you about our experience, which we presented at AHNS Austin last year. So when we talk about total thyroidectomy followed by radioactive iodine for newly diagnosed disease, the proponents of radioactive iodine ablation have these 3 points that they always mention. They think that they can optimize surveillance. They really want to make sure that you have more peace of mind when you talk about a patient, when you make sure that the patient is doing well. You can use thyroglobulin as a serum marker regardless, but the proponents of RAI for intermediate risk disease will talk about the more sensitivity of thyroglobulin in a setting where radioactive iodine ablation has already been done. So microscopic disease has been taken care of, and the multifocality of the disease. Again, multifocality is by and large taken care of by a total thyroidectomy, but their point is also that there are micrometastases in the lymph nodes. Now, this is not necessarily what we as a center would conform to, but these are the arguments that are raised. We do know that there is evidence for radioactive iodine, and there's a lot of papers, but we want to keep it sufficiently basic as well as to make sure that we're able to tell you about some notable studies. We know that radioactive iodine reduces risk for recurrence with no significant reduction in overall survival. That's important to know. So for the most part, it is about minimizing the risk of disease recurrence without an improvement in survival. If you decrease the risk of recurrence in a disease which is high risk, which has a modest survival rate, that is understandable. But using it for intermediate disease has its some caveats. We know that older patients and larger tumors, typically the benefits are more. And in a study by Saman et al., the treatment with radioactive iodine was the single most powerful predictor of DFS and recurrence prevention in DTC. Having said that, there are certain groups which would be candidates for radioactive ablation and some which would not be. So remember, the table on the left is important to know because remember, there are new risk features of low-risk thyroid cancer that have been elucidated since 2015. So for ATA low-risk DTC patients, we do not routinely recommend radioactive iodine ablation. For patients with after lobectomy or total thyroidectomy for unifocal or multifocal microcarcinoma, it's not recommended. It's considered in intermediate risk and it's routinely recommended in high risk. So that's actually making the story easier. Low risk generally don't use unless there are any compelling indications or any significant or specific factors that compel you to use it. For high risk, definitely consider using it. And intermediate risk is something we need to explore a little further. So let's look at another intermediate risk patient. Contrary to the last patient with intermediate risk that we talked about, the last patient was risk in view of the size of the tumor, but this patient is intermediate risk in view of the gender as well as the fact that the patient has multiple studded lymph nodes along the lateral cervical chain. This patient has a Bethesda 6 thyroid nodule, and as you can see, prep during the surgery, you have this kind of field at the end of the surgery where a lateral neck dissection as well as a central compartment in conjunction with a total thyroidectomy has been done. So it's a classical papillary carcinoma. Last one was follicular, but again, it was not aggressive follicular. So histologically, they were not very high grade. 15 lymph nodes are positive. And again, even by MSKCC criteria, this would be a patient that would fall in the subset of patients who would benefit from radioactive iodine. There is no extrathyroidal extension, focal or otherwise. There is vascular invasion. So again, looking again at this kind of subset, and this is an algorithm for a patient that we just discussed, a total thyroidectomy with neck dissections, you again evaluate your postoperative disease status. In these patients, remember, you might be committed to just doing thyroglobulin like we still are at our center. But remember that whenever you do serum thyroglobulin, you always have to test for anti-thyroglobulin antibodies. Only when anti-thyroglobulin antibodies are low or undetectable can you use serum thyroglobulin as a reliable marker. So in patients with low risk ATA or low risk thyroid cancer per se, patients who have raised antithyroglobulin antibodies really limits us a little bit, because then we have to go to the gold standard, which is radioactive iodine scanning. Having said that, this patient is the intermediate risk candidate where you might want to consider radioactive iodine scanning a little more seriously. And the guidelines indicate the same. What the dose is going to be, is it going to be an empirical dose or a dosimetric dose? We'll talk about a little bit. But typically, a patient like this, depending upon the uptake and the amount required, you'll have to use doses of as low as 30 millicurie going up to 150 millicurie for remnant ablation in the thyroid bed, which is non-metastatic. The TSH goal in intermediate risk disease remains the same. Remember, we have to suppress TSH, and we'll talk a little bit more about that when we talk more about biochemical indicators. And evaluation of response to therapy now, once you've already committed to a radioactive iodine uptake scan, you will at least have to do one more along with a neck ultrasound and thyroglobulin testing. Subsequently, using DRS, you classify them into excellent responders or one of the incomplete categories, and thereby move forward. So intermediate risk disease is really has two kind of subsets, which we talked about. A patient with a large primary tumor with minimal nodal disease, and a patient with widespread nodal disease, in which case, the latter case, you would consider at least radioactive iodine scanning and thereby take a call depending upon whether you are an institution that conforms to the empiric mindset or the dosimetric mindset. We try to be as dosimetric as possible. Remember, your tumor boards are perfect places for discussion for the same thing. You always, as surgeons and as oncologists, all of us want objective criteria to be able to treat our patients. But again, there is a significant subset of nuclear medicine physicians who will follow empiric subset based on perceived aggressiveness of disease. Moving on. Another patient. Remember, we've talked about low and intermediate risk, and we know that for high risk, by and large, we would consider radioactive iodine. But let's take a case vignette into view, especially for the younger minds in the audience, so that we can take it forward. So again, a male, elderly, beyond the age threshold for low risk disease, has abutment and on potential invasion of cervical trachea. On the image, intraoperative image, you can see a tumor thrombus, which is intraluminal within the internal jugular vein. Even though that's not been classified as invasion per se, because it's non-focal and non-contiguous, but despite that, you would the marker of aggressiveness, and there are multiple ipsilateral lymph nodes. So the patient ends up getting a total thyroidectomy, a level 2 through 5 neck dissection with a CCND and a tracheal shave. The final path is polydifferential carcinoma. Remember, we have the Turin proposal to help us decide that. There are 9 out of 45 lymph nodes positive with ETE. There is capsular and vascular invasion, and the tracheal margin subsequent to the shave is negative. Now, this constitutes high-risk disease. And these patients are treated with a different algorithm. Already, you are in a setup where it is going to be considered, but by and large, it would be considered in a little bit higher category. Why? Look at the table on the left. You'd have to assume that if there's gross ETE and incomplete, and you have to potentially assume an incomplete tumor resection, because even though you've gotten a narrow margin around the disease, here is where the multicentricity comes in. Even if the patient does not have distant metastasis, you are committed to making sure that the disease bed is sanitized, and also you want to avoid the sink effect. So you do a complete resection, make sure that you get your radioactive iodine scanning, make sure that the disease is not in other parts of the body, because remember, you're not really doing a metastatic workup till the time that you do a radioactive iodine scan. And that's another advantage that the proponents would typically. In this kind of patient, we would do radioactive iodine ablation following scanning to sanitize not just the local bed, but the regional bed and the distant areas also to prolong survival. And we know that there is prolongation of survival by choosing radioactive iodine ablation in the metastatic as well as the non-metastatic setting. So using these 4 case vignettes, we've transcended the spectrum from low-risk thyroid cancer to high-risk thyroid cancer. The intermediate group we've divided into 2. One which does not have lymph node metastasis, and one which has lymph node metastasis, and therein our decision for radioactive iodine kind of gets tailored. While we talk about radioactive iodine, and we'll go a little bit more into the detail of that, it's important to know that we cannot consider radioactive iodine scanning in isolation. We will have to consider other goals, our biochemical goals in terms of thyroglobulin, making sure that we assess the reliability of thyroglobulin through the testing of antithyroglobulin antibodies, and also to make sure that you supplement it with either ultrasound or cross-sectional imaging, and we'll talk about that, with or without other testing, including TSH suppression. So we'll talk about all that as we go on. Remember now, talking in isolation about radioactive iodine, there are different doses that are used for scanning, for recurrent disease in the thyroid bed, for residual disease, for pulmonary mets, and for bone mets. Let's look at a little bit more of this. Remember, thyroid bed disease and low-risk thyroid cancer, there is enough evidence that you can ablate it with the so-called OPD dose or something less than 49.9 millicuries. This is a strong recommendation with high-quality evidence. However, if you have suspected microscopic residual disease, then doses of up to 150 millicuries are used. I hope that there are some nuclear medicine physicians in the audience, because if they are, they would be able to add some more light on dosimetric dose versus empiric dose. Dosimetric dose essentially entails that you're tailoring your dose depending upon the uptake, and empiric doses are based on the perceived aggressiveness of disease, like we talked about. One word of caution: if you do empirically administered doses of iodine 131 more than 150 millicuries, you should potentially avoid that in patients over 70 years. So dosimetric dosing would probably be the case that you do in that. Once you've ablated, you have the standard precautions of a low iodine diet, and a post-therapy whole body scan is typically recommended to make sure that your target has been achieved in terms of concentration within the thyroid bed, and it's actually a source of great reassurance to the nuclear medicine physician as well as the surgeon. Remember that if empiric radioactive iodine therapy is given and the post-therapy scan is negative, at that time the patient is a strong candidate for being considered to have radioactive refractory disease. But we'll leave that thought for a while, and we'll talk about refractoriness later as well. Just to get the point home, that post-ablation scans are typically done after radioactive iodine ablation. Some nuclear medicine physicians believe that after a low dose therapy, a post-ablation scan is not required. But I think for the most part, the subset that we are concerned about are the patients with intermediate or high-risk thyroid cancer, in which you would want a post-therapy scan to make sure that you're not dealing with distant metastasis, because usually that would be the case that we would have. The sink effect kind of negates itself in that sense, and we want to make sure that it's also going to the metastasis per se. Remember that radioactive iodine is not a free shot. There is evidence that is insufficient to recommend for the routine use of measures to prevent salivary gland damage. However, we as a center, we always do something called the salidinitis protocol. We increase their oral fluids. We start salagogs, just local salagogs like lemon, just to make sure that unless there's any comfort issues or any contraindications to that. And we also tell them to overuse their muscles of mastication to make sure that their salivary ducts keep on pumping. Remember, caries prophylaxis is also important because there is a predisposition secondary to xerostomia. And surgical correction can be considered for nasolacrimal outflow obstruction, even though in our experience, we don't really find that much. For the most part, we find xerostomia as an essential surrogate of radioactive iodine in most of our patient subsets. Talking about the caveats of radioactive iodine therapy again, you have to monitor them, especially the ones who receive multiple doses for risk of secondary malignancies. And usually the risk of secondary malignancy max at about 500 millicuries. So this would only be applicable to patients with recurrent thyroid cancer, the ones that have received more than at least 2 doses, and metastatic thyroid cancer who received more than 2 or 3 doses. Therein, increasing the cumulative dose. Remember, toxicity in radioactive iodine is not idiosyncratic, it's actually dose dependent. So there are risks not just with regard to secondary malignancies, but there are concerns with regard to safety, and a lot of them are gender specific. Women of childbearing age avoid pregnancy for 6 to 12 months, and men receiving radioactive iodine activities more than 400 millicuries should be counseled on potential risks of infertility, even though we've not had a scenario like this. But again, in terms of infertility, but women of childbearing age are always advised, and that is regardless of what of the indication for which the radioactive iodine is being used. You ask them to avoid pregnancy and lactation or have any alternative methods to lactation in that respect. So moving beyond radioactive iodine, remember that one essential component of post-treatment is the monitoring of TSH, and to make sure that it's stimulated at the time of testing and suppressed at all other times. Again, suppression and stimulation would depend largely on the risk category of the tumor. So you do your endogenous withdrawal. There are 2 ways in which you can stimulate TSH. You can either withdraw TSH like we do for most of our patients, We used to follow the 4-week norm. Then we realized there are patients who are having a supra-threshold stimulus of TSH, and we started doing 3 weeks. What we realized with time was that 80% of our patients were able to be adequately stimulated, which means reaching a TSH of 30 or higher after 3 weeks. So that's the protocol that we currently follow. We document the patients who are going to take a longer time to withdraw. Most of those patients, if you look retrospectively, will be patients with high-risk thyroid cancer because their TSH would be suppressed to undetectable levels. In their cases, TSH would typically take time to rise. So for low-risk thyroid cancer, we've started withdrawing only for 3 weeks, and therein we avoid any intolerable symptoms of thyroid hormone withdrawal. Liothyronine has very limited availability here, so I'll skip that part. In terms of exogenous withdrawal, when you have to do testing, either in terms of stimulated thyroglobulin or radioactive iodine, recombinant TSH has emerged as a good tool to help us stimulate without going through the symptoms of withdrawal that we typically have. Remember, it's thyrotropin alpha. You need 2 injections, 0.9 milligram IM, and then 2 days after that, you can do it. The 2 indications that it's recommended for are the follow-up of patients with well-differentiated thyroid cancer, and the other way is a fast-track protocol in which you can use it to fast-track ablation in patients with metastatic or non-metastatic thyroid cancer. I must admit, we don't believe in the second category, so we have not used it. I think we mentioned that yesterday as well. But we use it very selectively for patients with severe thyroid hormone withdrawal. There is evidence, and I'll very quickly skip through that. The patients who have a total hormone withdrawal or thyroid hormone withdrawal, they get comparable benefit based on this data. In low risk, it's said that if you use recombinant TSH and low dose radioactive iodine ablation for post-operative management of low risk thyroid cancer, that might be helpful. This was a paper that gained a lot of headlines in 2012. Having said that, in our setting, the application of usage of radioactive iodine for low risk thyroid cancer is anyway extremely limited, so we don't really conform that much to it. Again, another paper in NEJM which attested to the same, and it included the subset of intermediate risk patients also. This, of course, is the subset that we are more concerned about, high-risk thyroid cancer. And again, the caveat in this paper is that they did not include metastatic thyroid cancer. So far, we know that metastatic thyroid cancer, you have to really treat this thing with caution. Why? Because TSH is trophic to differentiated thyroid cancer, and you really don't want suprathreshold levels beyond what you need for scanning. Leave of absence is a quality of life indicator. This paper attested to that. And of course, there was more quality of life data in this as well. But remember, the recombinant TSH does come with its advantages, but you do have disadvantages also. There is going to be a transient nature of hypothyroid symptoms because a suprathreshold TSH will take some time to return to normal, much more than with endogenous withdrawal. A lot of countries don't cover by insurance. The few patients that we've used it for are mainly patients who were empaneled by different agencies. The trials are non-placebo controlled, and the safety profile in metastatic thyroid cancer really makes it difficult for us to apply it more widely. It may be indicated in selected patients while with underlying comorbidities where you don't really want to, basically the ones who have severe symptoms of thyroid hormone withdrawal, in patients with pituitary disease, and that's a definite indication where TSH cannot be raised, or patients in which a delay in therapy might be deleterious. So our philosophy is the one outlined at the bottom, and this wraps up our philosophy on recombinant TSH. Cost has to be factored, and we only use it in affording or empaneled, covered by insurance, high-risk patients with significant anticipated or experienced withdrawal symptoms. And when I say high risk, I don't mean high-risk thyroid cancer. I mean the patients who are at high risk of endogenous thyroid hormone withdrawal because of the reasons listed above. Remember, TSH stimulation is another matter, but TSH suppression is something that's well established in the armamentarium of long-term management of differentiated thyroid cancer. We talked about the fact that long-term increase in TSH is not appropriate because once you suppress TSH in differentiated thyroid cancer, of course, you know that locoregional and distant relapses can be significantly reduced. However, when you suppress long-term, you want to make sure that your cardiac toxicity and bone toxicity has to be factored into account. So you don't really want to suppress or over-suppress a patient with low-risk thyroid cancer too much. We also have data which indicates that relapse-free survival was improved in cases where TSH was adequately suppressed. But remember, the key is adequate suppression. How do we suppress TSH, and to what extent do we suppress TSH? It's largely driven by the fact that your suppression has to be driven by the risk category. So in a low risk differentiated thyroid cancer patient, status post thyroidectomy with or without radioactive iodine, TSH will be maintained at the lower limit of normal. So you keep it around 0.5. In the very low risk category, like the first patient that we talked about, you can keep it between 0.5 and 2. However, in a high-risk patient, in a recurrent patient, and whenever you have demonstrable persistence, complete suppression of TSH to the tune of 0.01 to 0.1 should be considered. You start a dose which is in line with the risk category, and we'll talk about it in the Q&A, how we start the initial dose and how we subsequently titrate it. Thyroglobulin, of course, is an essential surrogate of follow-up and management of thyroid cancer as well. We know that a level more than 10 nanograms per milliliter is typically considered suspicious for disease recurrence, but it also depends on what technique you're typically using it for. Remember, and we already covered it in the tables in the 4 case vignettes at the beginning of this talk, but very low risk or low risk thyroid cancer, thyroglobulin does not need to be monitored more than yearly. But intermediate and high risk thyroid cancer, in which case you are stimulating the TSH anyway for radioactive iodine scanning, we typically prefer testing with thyroglobulin. Remember, whenever you test with thyroglobulin, you always get a complement of anti-thyroglobulin antibodies along with. And differentiated thyroid cancer, actually 25 to 40% of patients have circulating anti-thyroglobulin antibodies, and a declining trend of anti-thyroglobulin antibodies typically indicates that it is a favorable prognostic factor. Post-radioactive iodine ablation we've already covered. An ultrasound may be considered for intermediate or high-risk disease, but if you're committed to doing radioactive iodine scanning, you don't need to do ultrasound routinely. An ultrasound typically forms the mainstay of follow-up for low to intermediate risk thyroid cancer. And the same criteria I use, someone asked me yesterday about how they use Bethesda and TIRADS together in the setting of recurrent disease. And remember, we typically use it just the way we would earlier. Having said that, there are certain limitations that our radiologists have in the setting of a fibrosed thyroid bed because these patients have been operated, all of them. What about a PET? Someone asked me about Tennis syndrome yesterday. I think it was Kinjal. The Tennis syndrome essentially is an acronym for thyroglobulin elevated negative iodine scan with a single N. What it indicates is that patients who have an increasing trend of serum thyroglobulin with the low anti-thyroglobulin antibodies, but with a negative iodine scan. Remember, the radioactive iodine scan the PET scan is indicated for these settings. Remember, it's never indicated at the initial management of thyroid cancer or the initial staging. But in the Tennis syndrome, which Kinjal asked me about yesterday, you do want to apply it, but very selectively indeed. And we'll talk a little bit more about that later. A CT and an MRI, I'm glad that we did not have too much time in between the loss of signal. But you do cross-sectional imaging if the risk category indicates. So if you're dealing with invasive thyroid cancer and you have to follow it up, cross-sectional imaging does form a very, very important part. Also in patients who had bulky nodal disease, evaluating the central compartment, there is going to be a demonstrable benefit in picking up through cross-sectional imaging whatever we are hoping to achieve. We presented our own data at the American Head Neck Society in Austin last year. One of our fellows, Karthik, I think, who was there yesterday as part of, and he's your city mate, Bhargav, settled in Hyderabad after his fellowship. We looked at whether dynamic risk stratification actually has a role in the setting of Indian patients, but we compare it with a very easy tool. We compare it with clinical examination alone. We realized that DRS does have advantages. Cost implications are not that many because actually it aims to conserve resources by avoiding excessive over-treatment in excellent responders, therein making them more compliant, calling them less often, and making sure they comply to your schedule. There are resource constraints, of course. So there are some settings in our country, especially. Remember, BARC data, we talked about it yesterday, indicates that there are only 160 nuclear medicine centers in our country. Comparing that to the lakhs of thyroid cancer that all of us think we have, and of course the other nuclear medicine indications, makes it really very difficult for all patients to avail of nuclear medicine facilities. Clinical examination alone is not sufficient, as we know, especially in intermediate to high-risk thyroid cancer. So DRS is helpful because that really conserves the resources for the patients who actually need it. So initial risk stratification would not be the only indicator which would help us decide one way or the other. Dynamic risk stratification does have some advantages, and we'll talk about it in the Q&A as well. We'll wind up our conversation about other modalities for utilization. Radiation therapy has very limited role, usually in unfavorable histology or recurrent tumors. So always make sure to discuss it in your multidisciplinary tumor board before taking a call on further management. Some studies have been done, and of course, patients who are unresectable and non-iodine avid, those patients will typically benefit from radiation therapy. But again, it's very histology specific. So make sure to discuss it with your radiation oncology colleagues before you move ahead. But remember that there's no role for routine adjuvant external beam radiation therapy, and there is no role for routine adjuvant therapy in patients beyond RAI and or TSH suppressive therapy using levothyroxine. I've already covered that. So remember, radiation for very, very select indications. Chemotherapy and monoclonal antibodies and kinase inhibitors, we'll talk a little bit more about that because it's extremely important in the setting of radioactive iodine refractory disease. In the old ages, doxorubicin was the only agent that was FDA approved, and that was the case till just a few years back. And whenever other combinations with cytotoxic agents were tried, it did not really have a benefit. In fact, the only modest improvement in survival from anaplastic used to be from a regimen of adriamycin and low-dose radiation therapy. Therein came in sorafenib and sunitinib. Currently, sorafenib and lenvatinib form two options for radioactive iodine refractory disease. So remember, systemic therapy or monoclonal antibody are typically only used for patients who have refractory disease or where the other options for therapy are either exhausted or are refractory to it. Remember that the subset of patients with recurrent nodal disease, and we'll only talk about a case vignette of recurrent nodal disease, you know that the risk of structural disease recurrence goes up along with the risk category, which is also why dynamic risk stratification is a little important, because initial risk stratification loses its significance, let's say a few years down the line. So you really want another tool to make sure that it's able to categorize your low risk patients based on the response or long-term response to treatment, or upstage low risk, keep the stage the same, or downstage higher risk tumors. There are scoring systems, and it's quite ironic that Professor Ito, who advocates active surveillance for papillary microcarcinomas, has also done us a favor by devising a scoring system in terms of risk for lymph nodal recurrence. Less people know about this, and a lot of them know about the so-called Ito tumors. But remember that when you have lymph nodal recurrence, that is an adverse prognostic criteria in terms of overall survival. We have a case vignette for you, which will help us define, again, surgeons in the audience, and I want to make sure that you're adequately engaged. We have a case vignette for you in terms of defining safe limits for central compartment surgery. So we'll talk about a patient who was referred to us. It happens a lot in your practices also, who was retrospectively staged low risk, status post total thyroidectomy. So it's a low risk post total thyroidectomy, and we did a stimulated thyroglobulin alone. The antithyroglobulin antibodies were raised, and this was about immediately upon presentation, and it was negative. Then 6 months later, we decided to do another thyroglobulin. There was a decreasing trend, but radioactive iodine uptake scan showed uptake in the left paratracheal region, and a high resolution ultrasound corroborated that. We did not think the need for a cross-sectional imaging in that sense. So we have challenges, of course, in redo central compartment surgery, what incision to utilize, especially in pre-sternal migration in elderly females, how to preserve the recurrent laryngeal nerve, parathyroid, and identify all disease foci. And the plan of course, a disease-directed left central compartment clearance with a delineation of anatomical limits in a recurrent setting. In this case, unless the scar has migrated inferiorly, it's another scenario, but for the most part, you'll be able to utilize the same scar if the patient presents to us a few months after. Remember, there's no midline raphe. This is superior, and inferior is actually superior on your screen. So you find your neo-raphe. Anterior jugular veins are usually not a landmark in redo central compartment surgery. Remember, we talked about defining limits. So your anterior limit will be the sternohyoid unless it's been resected. In this case, we talked to you about it being a low-risk thyroid cancer, which was retrospectively staged by us and underwent surgery outside. So you can use sternohyoid as an anterior limit. Just like in per primum thyroid surgery, if your sternothyroid is still intact, the division should be on an ad lib basis if you think you require it for exposure. Remember that once your anterior limit of the sternohyoid is identified, you hug the undersurface to define the lateral limit. And the lateral limit is going to be the common carotid artery, just like it is for per primum central compartment surgery. So you start with your anterior limit, you follow it or hug it till you reach your lateral limit, which is the common carotid artery. Again, the side of the Langenbeck is superior, and the side from where the Kelly is coming in from is inferior. So you get your carotid sheath, and you visualize. This is for the sake of demonstration. Sometimes you don't really need to go that lateral in reduced central compartment. Once your lateral limit is also identified, I think Pallavi asked us yesterday about this, whether or not the thymus would be incorporated. Tackle the thymus if it comes in the way, otherwise not. Remember that the thymus is also going to bring its thymic veins along, which will be leading to the innominate vein. So you'll find these tributaries, and it's always best to control it. Tackle the thymus only if it comes in the limit. So if it's a thymus that's reaching up above the innominate artery, which is the inferior limit of the dissection, which is well visualized now, in that case, you go ahead and control that as well as reach the bottom point. So this is the inferior limit. The inferior limit is the innominate artery. We've now identified our superior, our anterior, our lateral, as well as our inferior limits. Remember that when you dissect already dissected thyroid bed, you are concerned about parathyroids. We talked about parathyroid preservation yesterday. You really want to make sure that you're able to distinguish that, and the frozen section really comes in as a good tool. So you use a small 11 blade to get a sliver, but like I talked about yesterday, you let the remainder of the parathyroid candidate remain in situ. Frozen section really would help you a lot in terms of identifying how whether or not you have a parathyroid or something else. Recurrent laryngeal nerve is identified at the cricothyroid joint, and only after that is done, you can see us clipping the small branches of the inferior thyroid artery and dissecting further. Here you can see the skeletonized recurrent laryngeal nerve. Someone asked me yesterday whether a vasa nervosum is an identifier of a recurrent laryngeal nerve. That is not the case, but yes, confirmation of an intact vasa nervosum is a huge thing that is a source of satisfaction to any surgeon, especially after redo central compartment surgery. So now we've gotten our superior limit. Our superior limit is the cricothyroid joint. We've found our anterior limit, the sternohyoid, the lateral limit, the carotid, medial, of course, the midline or the trachea, and inferior, which is the innominate. So once you define your safe limits, and see here, you can see the intact vasa nervosum right on top of the recurrent laryngeal nerve and preserved parathyroids. Once you have some kind of an idea about how you define your limits, you will typically be able to tackle it in a little more structured fashion. So yes, by all means, you could tackle the limits separately. Remember, the anterior limit always has to be addressed first, but you could choose to go down to the medial limit first and then go in. Admittedly, there's going to be sometimes much more distortion than we would otherwise imagine. And parathyroid preservation is something which will really need a lot of application of intraoperative cytology, a lot of experience in terms of picking up colors, having a low threshold for reimplantation, and utilizing the principles that we talked about yesterday. Very briefly about radioactive iodine refractory tumor. We talked about it very simply put as a disease, metastatic or locoregional, which does not concentrate radioactive iodine. And when a patient with DDC is classified as refractory to radioactive iodine, there is purportedly no indication for further RAI treatment. Having said that, there is a subset of investigators who believe in reiodination through retinoids or selumetinib. We don't really use selumetinib that often at our institution, but I know there are institutions, especially European, who would be using it a fair bit. Remember that mutational testing, and this is again someone asked me yesterday, is not routinely recommended for prognostic purposes in patients with the more difficult to treat varieties of thyroid cancer. Other modes, again, not mentioned to be standard of care, but there are things that have been explored: stereotactic radiation and thermal ablation, and glucocorticoid therapy prior to radioactive iodine therapy, and all those things have been tried. But again, it is not something which would be considered standard. The final point, of course, we talked about it briefly, and just like yesterday, today Bhargav was telling me that he's gotten a fair number of requests from all of you guys who want the PDFs. He'll share my email address with you, and I'll be happy to mail it to you. So without being very esoteric, remember that typically the kinases and the pathways that we use for refractory disease are generally limited to either sorafenib or lenvatinib. Lenvatinib has less toxicity, but it's limited by cost constraints and availability. Okay, great. So we've tried to briefly cover over the last 30 odd minutes about adjuvant therapy, about surveillance, as well as just giving you a brief case vignette of recurrent nodal disease in the central compartment. I think we can probably have a couple of questions, Bhargav,
Yes,
maybe
sir.
before we move on. It's your call because it depends on how many questions you have in the dialog box currently.
Sir, actually, as of now, there are just only a couple of questions. That's all, sir.
Okay, so
Dr. Kiran Joshi, yeah,
yeah, sure.
Dr.
Go ahead.
Kiran Joshi has been asking. He has a case of post-total therapy with central neck dissection as well as lateral neck dissection. In the follow-up, which shows thyroglobulin of 2, anti-thyroglobulin antibodies of 150. I specifically asked him what is a TSH. RA is clear, and TSH he was not able to mention, but he was asking what to do about that.
Yeah, so we'll take both scenarios. It's a very relevant question.
Yeah.
If the TSH is adequately stimulated beyond 30 to 35, the thyroglobulin that we're talking about currently, let's say that it's adequately stimulated or inadequately stimulated. If your TSH is not 35, then I would wait for another week and a half. But I'm assuming that you did the right thing by waiting till the TSH was more than 30 to 35. If the TSH was adequately stimulated and you get a TG of 2 and an anti-TG of 150, now anti-TG is raised in this circumstance, your radioactive iodine scan is negative. I would typically treat this patient as you. Did we mention the staging? Was it a low,
Uh,
intermediate, high risk?
I think 1 second, sir. Patient is the highest patient with
Okay.
targeted TSG less than 0.1 international units.
Okay. So if a patient is a high risk patient and has a negative radioactive iodine scan, depending upon the philosophy of your nuclear medicine physicians at your institution or to your referring institution, they might believe in the empiric mindset. If they are on the empiric category, you would consider giving an empiric dose to this patient, knowing that there's a possibility of microscopic residual. However, if you belong to the dosimetric category, then in that case, there is no indication for therapy in this case. What we would do at our institution, not really playing the devil's advocate, I'll give you a clear answer. Our philosophy would be to give this patient anywhere between 50 to 100 millicuries because of the fact that the patient is high risk. And if there is no demonstrable metastatic disease, you know that the disease is limited to the thyroid bed. The caveat in this case is that the anti-thyroglobulin antibodies are raised, which are preventing the usage of thyroglobulin as an effective marker. But you have to assume that the patient has some biochemical persistence, which has to be treated at that setting. That will really make it easier for us to monitor the patient in the postoperative follow-up period.
So next question is, does really transplantation of the removed parathyroid gland work? And if so, when to expect it?
Yeah, great question again. Yesterday when we talked about parathyroid preservation, we talked about a European study. There's also meta-analysis in the World Journal of Surgery. The first question that all of us surgeons ask is that in this age of objective medicine, just chopping up tissue or homogenizing tissue and just putting it somewhere else work or not? And the answer is most definitely yes, it does work. If you look at the meta-analysis and in that European study, and there's a bunch of studies that have been done, the number of transplanted parathyroids eventually had a correlate with PTH that the patient was eventually able to achieve. Remember that I'm assuming that all of you have had reasonable experience in thyroid surgery. The scenario of having an undetectable PTH after a thyroidectomy should not really arise. So all you're doing is an alternative method of parathyroid splinting by getting as much tissue that has been amputated and then reimplanting it. So the answer is always reimplant, one. Number two, try to make sure that don't leave devascularized parathyroid glands in the bed. It would be much better if you get them into a vascularized pocket. And always make sure that your patients counsel them that it might take 6 to 12 weeks for the PTH to start showing some sign of normalcy, because that's when vascular absorption really takes place. The fibrosis cascade comes down and the absorption comes in. Having said that, most of your patients who have one or at most two glands reimplanted should also have two functioning parathyroids, and it should not really take that long. So it's variable, but you should tell the patient up to 12 weeks so that you are not in that scenario that the calcium is not rising and therein you go into a problem because you've not prognosticated the patient.
So next question is by Dr. Vincent. What is your principal for tracheal invasion management, in your opinion, your principles?
Sure. And we talked about it yesterday, Vincent, and I'll be happy to point it out again. If it's grade 1 shin classification, then we normally do a laryngotracheal shave. Now, it's difficult to predict how invasive thyroid cancer is going to behave. So a stage 1 shin might be different from another stage 2 shin. But for the most part, you rely on the residual integrity of the remaining tracheal framework and you do a shave. By a shave, you mean removing partial thickness of the ring of the tracheal cartilage and letting the other scaffold take over. In grade 2 invasion, we talked about it yesterday also. This is the disease that is not intraluminal. That's extraluminal, but the abutment is a little more than would be treated by a shave. In that case, you do a narrow margin resection and look at your defect. If it's only a wedge defect, then in that case, you would be okay doing, we prefer a vascularized subhyoid flap because the whole area is exposed. The sternothyroids are relatively vascular and the hyoid bone is right there as well. You can use a wedge of hyoid in that area and use the sternohyoid muscles as a buttress to make sure that there's no leak. Remember, if you're using the subhyoid flap, we normally use passive suction drainage. We don't use vacuum suction drainage. For stage 3 and stage 4, there really is not much option except doing a tracheal resection and end-to-end anastomosis because you're dealing with disease now that is intraluminal. You're dealing with disease that will produce airway issues as well as a drop in survival. But before taking up a patient for a tracheal RA, you want to be absolutely sure that the disease is resectable and repairable. And we talked about that yesterday as well. 25% of the entire tracheal length is typically something you can use without interpolation. But there's some elegant literature, and we've done a couple of cases also where you use a scaffold, use a radial forearm free flap for tracheal lengthening and other ways.
One more interesting question by Dr. Joshna. Could
Yes.
you just comment on a low-dose scan? The follow-up, the initial total therapy follow-up, I think.
The role of a low-dose scan, I'm sorry, is that what you said?
Yeah, LD scan.
Yeah.
LD scan, it's a low-dose scan.
Yeah, so a low dose, see, remember that scintigraphic diagnosis are not made on, let's say, a fraction of a millicurie. Most nuclear medicine physicians that you will talk to will ask you to use at least 2 millicurie for your post-thyroidectomy scans because there is something called the sink effect. The sink effect essentially entails that any microscopic residual in the thyroid bed will pick up everything therein, preventing the possibility of picking up a distant met. Low risk thyroid cancer also, remember, is stratified ATA low risk only because there is no demonstrable distant metastasis, which is something that you're going to pick up only later on as you extrapolate the results of a radioactive iodine scan. So at our center, we would use a minimum of 1 to 3 millicurie. It will be dependent on the age and the weight of the patient. From what I understand, again, I'm not a nuclear medicine physician, but if there is someone, I'd encourage you to opine on that. The low dose scan will typically be able to tell you if there is any quantifiable uptake. And after that, it depends on whether you belong to the empiric group or whether you're actually going to use dosimetry or quantification of uptake to decide. And from what I understand, there are advantages and disadvantages to both philosophies.
One more important question, interesting question on PET scan. If you are suspecting a distant metastasis, would you recommend commonly a PET in the initial setting to explain the prognosis, or else you go ahead with surgery and manage? There wouldn't be any change in the management. What he means to ask is, would you do a PET scan in the initial run if you are suspecting distant mets?
So, this is one of the indications where I would selectively use for a PET scan for initial staging. The only categories in which I'd use a PET for initial staging are very unfavorable histology. Patients who I suspect having a poorly differentiated or an anaplastic thyroid carcinoma, where the anaplastic is intrathyroidal, and I really want to make sure whether or not surgery will have any survival benefit at all. So in the unfavorable or the adverse prognosis patients, I would consider an upfront PET. But for the most part, in other patients where the mobility of resection or would be less, anticipated survival would be high, in that case, the role of an upfront PET would not be indicated.
And the next question is by Dr. Sujan. What could be the cause of RA uptake invariably in a total thyroidectomy After visually clearing the thyroid tissue from all parts, including the superior pole, RNL, Berry's ligament, nodes, etc. Even in TG when there is low TG.
Yeah, so that's a great point. And this vexed me shortly after the completion of my fellowship about 10 or 12 years back. That why are we getting scintigraphic uptake in the absence of anatomical residual? So shortly after I moved back to Punjab about 10 years back, we did a study on about 60 odd total thyroidectomies, where it was a single surgeon operated, and we were fairly certain that there would be no anatomical residual, but we still got scintigraphic uptake in the thyroid bed with the normal thyroglobulin. Remember that these patients are the ones that, again, you want to take to the multidisciplinary setting. In the series of 60, we were only able to correlate anatomical residual of 2 millimeters in one of those patients. So in 59 patients, we were getting scintigraphic uptake without any anatomical residual, which you would not expect in all of your thyroidectomies also. My take home for this would be just do a very thorough risk stratification upfront. Remember that we know that intermediate and low risk patients have a uniformly great prognosis. If you have a patient who was high risk to begin with, this question would be redundant because you'd be considering those patients for radioactive iodine therapy anyway. In low risk patients, you can safely observe it. In intermediate risk, you really have to do an interplay, like we talked about at the beginning of this presentation, and as to how much your perceived concern is. Combine that concern or lack thereof with the concern of the nuclear medicine physician and use your thyroglobulin as a guideline. There have been multiple occasions where we've observed a slightly higher reading of thyroglobulin in the absence of a radioactive iodine scan if the patient did not have intolerable symptoms of thyroid hormone withdrawal, and the thyroglobulin actually showed a decreasing trend, and we were able to avoid radioactive iodine completely. That being said, low dose radioactive iodine is actually not much morbid at all. I'm yet to recollect any patient who had significant salidinitis or xerostomia from a 30 millicurie dose. It's only when you go to the high dose or the intermediate dose setting, close to 90 or 100 millicuries, that you actually start getting any side effects. Most of these patients also would not be candidates for repeat doses. So the toxicities that we discussed, like we said, are cumulative and dose dependent. So it really does not play that much. But yes, use your risk stratification. That's probably the answer.
Sir. Next is a very interesting question by Dr. Rapin Shide. How does redifferentiating agents work in iodine refractory diseases?
Yeah, we talked about it, and we don't have any personal experience. I remember discussing this with Kumar Prabhash in the UAE Congress a few years back. The data on selumetinib had just come up, and it's not really utilized very often. Yes, there are great German studies, a couple of Japanese studies that say you are able to reiodinate. We don't have any personal experience because we as an institution believe that once a disease becomes refractory, you have more modalities on the horizon also. You have FDA approved agents now across the spectrum of thyroid cancer, not just differentiated, but you have options for poorly undifferentiated as well as for medullary, which are able to prolong survival of metastatic patients. So I think the combination of more options being there on the horizon, combined with the fact that reiodination really has very variable response rates, along with the cost implications that selumetinib brings with it, along with the concern about toxicity of the retinoids that we have, really has prevented us from using it in a routine setting.
Okay, sir. Next question is how long the thyroid suppression can be continued for total thyroidectomy with bilateral neck?
Yeah, that's a great question. I would assume that if you've done a bilateral neck, you at least have intermediate risk disease. So the answer is two-pronged, either intermediate risk disease or high risk disease. In high risk disease, we continue TSH suppression for at least till the period of dynamic risk stratification. And if the DRS shows the patient to be an excellent responder, like the tables that we discussed, we typically keep the TSH at about 0.1. That's because the lifelong thyroid hormone suppression, TSH suppression is going to have very deleterious side effects in terms of high output failures, tachyarrhythmias, cardiac toxicity, bone toxicity. In the intermediate risk category, we would typically keep the TSH between 0.01 and 0.5. And in those patients, we don't really have any demonstrable toxicity that the patient complains of. In high-risk subsets, we've had to decrease the dose of ultroxin just to make sure that the patient did not have tachyarrhythmias or anxiety or the other symptoms that would typically be associated with a hyperthyroid state. So to answer your question of bilateral neck, if it's intermediate risk disease, I would consider dynamic risk stratification and follow it to the letter. If it's high risk disease, I would suppress at least for 5 years and then use my results of the initial dynamic risk stratification to see how I'm going to take the patient from there on. But for high risk, usually 0.1 is the highest you can hope to go. You can't go higher than that. And for intermediate, you can't really go above 0.5 as a TSH marker. So we are going to be talking about recent advances now. So we'll talk about one recent advance that's very close to what we do, and it is actually remote access thyroid surgery that we'll be talking about. We'll talk about our experience. I won't talk about the evolution of remote access thyroid surgery as it applied to our center, but we will talk about we will talk about our experience with the robot. So, can you get the slide?
Yes, sir. We can get your slides.
Great. So remember that just like any other institution, we did a fair share of our trans-axillary non-robotics, and that's before we became a robotic center. This is the center that I work in, and this is the robot that we use. We use an SI system, and that is usually a 3-arm robot that we use. But then again, your question would be, why use a robot for a thyroidectomy? And we'll talk about the indications of the technique. The first concern, of course, that would arise in any one of your minds is whether robotic technology has resulted in selective adoption, or is it actually more like a mass hysteria? Remember that there is no surrogate of rapid adoption of the robot that can be better elucidated than urology. This is a very interesting paper which shows that robotic radical prostatectomy rates, or the increase in adoption of prostatectomy, increased much more when there were more robots available. So does it lead us to believe that just because there's a robot, we are doing robotic thyroid surgery? I think there's a little bit more to it than that. And of course, there is something called the innovation adoption life cycle. And remember, you have to be on the left of the curve. I see a lot of young minds listening to what we are speaking about right now and don't really want to be late majority and laggards. If you think some technology makes sense, and this is a nice thing that I got from non-medical literature, it's more technological from a symposium that I attended, that any technology that improves outcomes should be efficient, efficacious, robust, automated, scalable, personalized. A small footprint doesn't really apply to the Da Vinci, but the technology should be functional. And again, cost effective is a caveat, which we'll have to take with a pinch of salt, but we'll talk about how we've been subsidizing with the robot. Remember, and there is something to compare. A lot of people would think that remote access thyroidectomy is something which probably would be not only not cost effective, but also would have inferior oncological efficacy. Remember that a lot of this data comes from Korea. I had the good fortune to train with both Professor Chung and Professor Ko. Therein learning some perspectives about transaxillary as well as the retroauricular. The retroauricular is what we've done most of in the few cases that we have done. But if you look at data, all of them numbering in the thousands, they compare relatively okay with the open thyroidectomy in the robotic subset, regardless of whatever technology you use. Remember that there are limitations to this literature, and we'll be the first ones to admit that. In the time period that transaxillary thyroidectomy and retroauricular thyroidectomy came about, there is no head-to-head study between the two. So you don't really have objective criteria that help you pick between one and the other approach. It's largely based on surgeon bias. And there's anecdotal data of using both of them in a case, but then again, for the most part, you end up using one versus the other. We've tried to devise some selection criteria, and there are a couple of proponents in our country who've done a sizable number, higher than ours, and this is borrowed from our limited experience as well as from the discussions we've had from them. Remember that selection criteria would be largely based on the fact that if you look from top to bottom, nodule size more than 5 centimeters would typically not be tackled by the robot. Nodule location, we look at the distance from the retroauricular skin crease as well as the anterior axillary fold, and that helps us decide whether or not you're going to consider the transaxillary or the retroauricular approach. If you're going to do a neck dissection concomitantly, then definitely the retroauricular approach. There is some data emerging, and we're helping contribute to that about neck and axillary dimensions dictating what approach you're going to use. Normally, a higher BMI would help us. The retroauricular approach would be slightly easier because you don't really have that anterior chest wall to get through from. And if you have scar alopecia, then probably transaxillary is a little better. But at the end, it boils down to surgeon familiarity as to what we've been trained in. With regard to cost, India is very similar to other health systems in terms of the challenges as well as the solutions that we have to find. The challenges are the ones listed on the left. There is lack of awareness regarding remote access. Remember, remote access is benefited only in terms of cosmetic indications. We don't try to sell technology unless it makes sense. So yes, if a 30-year-old female is not getting her thyroid surgery done of a nodule simply because she's concerned about a scar in the neck and she thinks that we are trading one inferior cosmetic outcome for another, it makes sense to offer remote access to her. And remember that remote access need not be robotic necessarily. It can be other techniques also. Out-of-pocket expenses are another challenge that we have to contend with. But as insurance cover rises in India, and as we can subsidize a little more, and we'll talk about how we've been subsidizing at our institution, it is something which has become more affordable over time. Remember that one challenge is that people say that India is not a country where scar perception really matters that much. And to counter that, we actually did scar perception flyers when we thought we were on the precipice of being a robot institution. We did some awareness campaigns, we did robotic test drives. So we got good feedback from our patients as well as physician colleagues who thought that the region would actually need robotic technology. We were the first ones in the immediate region to bring it to this part of Punjab, and this was in 2018. And of course, this patient that you see at the bottom right is a patient advocate. She is the one who's been counseling our patients. And as you see, she had a 4.5 centimeter nodule initially. But you see the post-operative picture here. Her scar is not alopecic. In fact, she's beginning to have hair growth on top of it. This is about a month after the surgery. There's no bruising. At the end of the day, you might say that that whatever it might boil down to, eventually the cost subsidy is something that comes into the equation. So we then devised the retroauricular two-instrument thyroidectomy, which has actually become our go-to for most of our cases subsequently. There are certain modifications that we have to do to make sure that you're able to do a two-instrument thyroidectomy. The assistant instruments will be held by the assistant from the side of the patient, and here is the robot lever. They have to underhand the robotic instrument arm so that there's no clash. The exception is the thyroid grasper, which actually does the work of something called a prograsp. The assistant has to do multiple roles to be able to make sure that they're able to get a two-instrument thyroidectomy going. We'll talk about how we use this technology, and this is a standard retroauricular approach. And we'll talk about making the tunnel, and we'll also talk about how we do it. So this is the superior pole. You can see about a 3 centimeter nodule. This part has been shaved, and the retroauricular skin crease. Remember, the lobule is going to hide the superior part of the incision. Therein, you make a tunnel in this area, which is able to go all the way down to the thyroid. Herein you see the great auricular nerve and your external jugular vein. The challenge is finding the platysma, because we are going from a place where the platysma is deficient to another place where the platysma is deficient, which is the midline. Depending upon the access that you need, you create your tunnel, you get your Richardson retractors in, and you're usually going to need a self-retaining retractor, which you could borrow from your general surgery colleagues, or just take one of the modifications that the Koreans have designed. Once you have identified that, you encounter your thyroid nodule from therein, and remember, it's a magnified view. Once you get the self-retaining retractor in, so this is us docking the robot. So this is the instrument on the right side, and you're getting it in. The camera is in the middle arm. On the right side, for the most part, you will use an energy instrument. Either you'll use a monopolar curved scissors, which you'll be using in this case, and on the left side, you'll be using a bipolar. In this case, we're using something called the Maryland bipolar. So this is how it looks like eventually. You're going in remote access. Both your instruments are in place, and this is how the docked robot looks like. This is a panoramic view. As you go around the robot, here is the drape, and you'll get to something called the vision card. The vision card helps the assistant, and here you're in the robotic view. Remember, this is a two-dimensional view, but the surgeon always gets a three-dimensional picture. You're first going to the superior pole, like you do in most retroauricular thyroid surgeries, barring few exceptions like disease stuck over there. But by and large, you'll go to the superior pole first. When you go to the superior pole, you realize that there are two assistant instruments. One is the metallic yankor, which is currently being used to smoke suction, and the plastic yankor, which is being used for traction. On the left side, among the robotic instruments, you're seeing the Maryland bipolar, which is controlling that small tributary of the superior thyroid vein. And you're pretty much following the same principles. In this case, you're doing a bipolar of the capsule, and you're essentially working in an extracapsular plane. So you're working from superior, therein going to the medial part. This is the last branch of the superior pole that when you collect and then you dissect a little bit, that area shows you the external branch of the superior laryngeal nerve, which you can nicely identify. Once you go beyond that, it is time to go along the medial part of the superior pole, and then you go like you normally do in a thyroidectomy. You go to the area of the middle thyroid vein, which might be hypoplastic or otherwise. This is to demonstrate how we control bleeding during a robotic thyroidectomy. We use a barrel cottonoid either with vasoconstrictor or with saline, and usually it's as well controlled as it is otherwise. And remember, you have a bipolar in the field as well. You work now to the inferior pole, and you can see the parathyroid in the same location, and the parathyroid is preserved utilizing the same maneuvers. Remember, we'll show you 3 videos of 3 minutes each. But what we need to elucidate is the importance of the landmarks that are identified with a range of different instruments. This is the inferior thyroid artery. And like we know, in 70 to 80% of cases, it's going to course lateral to the recurrent laryngeal nerve, which you are identifying now in this area of loose areolar tissue, where the tip of the monopolar curved scissors is. Remember, you can use some laparoscopic instruments as well, and therein you get the exposure that you need. Let's look at the other parts of a thyroidectomy as would apply to when you use other instruments. Remember, the harmonic can also be used. You can see the harmonic on the right side now, and you can use something called a prograsp. We use the prograsp a little bit more when we know it's periisthmic disease, which means that we need to get the entire thyroid lobe up and over to one side. In this case, we are identifying the superior pole, and we are using the harmonic, but we also feel secure using one clip because it's a large pedicle and a named artery. Remember, in periisthmic disease, you identify the trachea and the isthmus a little bit earlier, and you need a bigger grasping forceps, which is why the prograsp comes in. So we'd use a combination of instruments, and you're seeing the part of the platysma deficient part where the retractor just ends, and you're using the harmonic now to come across the isthmus, initially superiorly, and now inferiorly, you're dividing across the isthmus, and you can see the nodule, which is about 3 centimeters in size. It was a Bethesda 4, and you can, even though you don't get any subjective, any sensory perception, you can actually feel against the wall and see the give on the vessel to decide that on the structure to decide whether you're on trachea or not. Utilize the same principles that we otherwise do, and utilize blunt dissection without any thermal charge to make sure that you are able to get to all the points of the thyroid that you need to. And herein is the recurrent laryngeal nerve that you see in the tracheoesophageal groove. And here you want to be especially careful that every energy instrument has a penumbra. So you don't really want to get to that penumbra too much. You want to stay at least 2 to 3 millimeters away from the nerve to make sure that there is no thermal damage to that area. Remember that all the studies comparing robotic to open thyroidectomy have shown a similar rate of oncological efficacy as well as recurrent laryngeal nerve. Here you're seeing a small branch of the inferior thyroid artery, which will be controlled with a harmonic fairly well because it's a much smaller vessel, about 0.5 millimeters, considering the magnification. So you know your recurrent down, you can now see the external branch of the superior laryngeal nerve also, and therein you're going to get that small cricothyroid artery, but you see the recurrent, which is dividing into 2 ramifications in this area, and you want to stay far away from it while you get complete control of the disease. So essentially, there'll be no residual even if you do a robotic thyroidectomy in this setting because you actually have much better magnification. Here's the disease that you have, and it's completely removed with extracapsular dissection. And you do some irrigation, and then you see the divided edge of the isthmus, and you want to be careful about bleeding in that area. Use your barrel cottonoids and get the hemostasis the same way that you normally do. We talked about periisthmic disease, but sometimes you really have a narrow working space. Remember that for TORS, we use 5 millimeter instruments, and sometimes we started using 5 millimeter instruments for robotic surgery as well. Again, skipping the initial parts, we are again down to the point where there is a very narrow working space because it's a thin lady, but she still has a thyroid nodule and she's cosmetically conscious, and we want to make sure that a hemithyroidectomy would be the standard in her case, barring any histological surprise. Again, you see some periisthmic disease, but you can probably see us spoiled for or constrained for some space over here, so that we don't have the space that we normally have to work with. So that's where the 5 millimeter instrument comes in. If you see the left robotic instrument, you'll see that it actually has snake arms, which helps us move in 7 degrees of freedom, which the harmonic will not be able to help us do. But the greater flexibility on one side really helps us move a little bit faster. Here you can see the superior parathyroid being peeled off in the prior step. And as soon as you do that, you start finding your nerve inferiorly. And the same principles apply again. The inferior parathyroid was lifted off there, and the nerve identification and the management thereof remains the same way as it would otherwise be during the process of an extracapsular thyroidectomy. So again, you come across your disease process, and remember, there can be nothing short of a complete hemithyroidectomy. You cannot have any residual disease, residual thyroid tissue, because you could be dealing with malignant pathology or otherwise as well. It's not good form to do anything less than a hemithyroidectomy in any setting, whether it be remote access or general. You get your final branches of the inferior thyroid artery with a clip, as well as utilizing a harmonic. And again, it's subjective decision whether or not you want to just use that or otherwise. And you get your specimen out, and just before that, you glimpse the recurrent laryngeal nerve. So, concluding, remember, remote access should not be synonymous with remote delivery. A patient like you see right now has barely perceptible, that transverse 1 centimeter is barely perceptible, and that's only if you look hard. But what's important is that in a young female like this, especially the one who's predisposed to hypertrophic scar, it is an option. Remember that the extent of scar perception might actually be similar in our populations compared to the rest of the Western world, and it could be irrespective of geographic location. So it's incorrect to assume that patients in our practice setting do not have a high scar perception. I practice in a tier 2 city, and scar perception, we realize through our flyers and through our little bit of data that we tried to collect prior to the robot, that it does have important considerations also. Remember that when you talk about financial subsidy, you can do some practice innovations. Just decreasing the number of instruments from 3 to 2, keeping it equally safe, we were able to save about 30 to 35,000 per patient. And currently, we are charging our patient only the cost of 2 instruments, as well as a routine thyroidectomy. And that would be something which a patient would generally be open to spending. Remember that no robot is only dedicated for head and neck surgery anywhere across the world. It is essentially a multi-specialty initiative. So you have to make sure that you do your part, but only in the indicated subset of patients. And there are definite implications of the 2-instrument thyroidectomy, we believe, in which you can use conventional instrumentation like we showed in the first video, as well as non-conventional instrumentation like we showed in the second and the third. So thank you. We'll conclude this part. And Bhargav, in case you think that we should go to the IONM talk, the intraoperative nerve monitoring talk, we can do that.
I think we finish off that and take the questions. There are multiple questions coming in.
Okay, great.
Finish off.
Perfect. So I know this is going to be, hopefully we'll be able to generate some controversy also about remote access. And therein we will be able to generate some controversy about IONM as well. So remember, intraoperative nerve monitoring is something which is utilized a fair bit. In our current center, we are not utilizing IONM currently. It's been on our plate for a very long time. I did use IONM universally. So the universal application of IONM was something I used to do in my part of my first fellowship, and then my entire 2-year second fellowship. But moving here, it was a different philosophy altogether, because you also have to get used to the idea of being able to make sure that you're using it selectively. So from a believer, I turned a little bit of a skeptic, but let's see what it offers. This actually is part of a discussion that we had at Tata Memorial Hospital as part of the 3rd annual meeting of the Indian Society of Thyroid Surgeons, where I spoke against the universal application of IONM in thyroid cancer. We will only talk about didactic aspects as they apply to the biophysics of IONM. And we'll talk about, we know that it might have select applications in indicated subsets, but one question that we have to address is whether you use it in every thyroid cancer and by extrapolation every thyroid surgery. And the answer is very definitely no. Before we start, because we will not be talking about the basics of the IONM, remember that how we do intraoperative nerve monitoring is well elucidated in this picture. You have a NIM tube, which is a nerve integrity monitor tube, which has electrodes on both sides, which stimulate the thyroretinoid by direct contact. And therein, you are able to get an amplitude on a screen that the electrodes are connected to. You also have grounding electrodes, which essentially means is that if you're monitoring the recurrent laryngeal nerves, and if there's any damage to them, at that time, you'll be able to pick it up and thereafter avoid further injury. Now, this is a very loaded subject. A lot of us think that yes, it has its applications, but we'll talk about why it is not justified in every thyroid cancer case or every thyroid surgery case. This was the title of a paper that I came across, and it kind of hits the nail on the head. Necessary, desirable, or dispensable. So is it something which you need every single time, whether it's something you don't need ever, or whether it is something in the desirable category that you'd use it for some patients and not use it in the others. So during the talk, we will talk about safety of the recurrent laryngeal nerve, which is essentially the crux of every thyroid surgery, along with the parathyroids. We'll try to outline objective indicators which help us decide whether or not it should be universally used. We'll talk about whether it is safe to use IONM in cancer. Some people say it is, some people say it's safer, some people say it's less safe and adds a complacency, but we'll talk about that. We'll talk about reoperative scenarios and how we can modify techniques and what is currently available. So remember when this technique started, they started applying nerve monitors to thyroid surgery, and then refinements of technique came about. Without any relevant financial relationships, Medtronic has a lot to do with intraoperative nerve monitoring and the way it's evolved over the last couple of decades. But here's a study. Again, we'll be quoting a lot of studies during the course of this short talk. 20,000 nerves at risk. So NAR is nerves at risk. Visual ID was the gold standard, but they said that there is a potential value in extended thyroid resections. So whenever you're doing something called a high-risk thyroid cancer surgery, you would be benefited in using it, but otherwise not, which is probably the philosophy that we're going to espouse. And we'll also talk very briefly about the caveats of the papers that we're going to talk about. Another paper, and this is older literature. We talked about the fact that, again, this patient has 6% nerve palsy, which most of us would agree would be unacceptably high in the contemporary setting. Again, this is older literature, but by the 2000s, the philosophy of routine identification of the RLN had come about. So they recommended it for the recurrent setting and cancer, which is again the so-called high-risk subset that we talk about. And another study, relatively recent, by Dave Terrace, who we talked about in the last robotic thyroid paper also. Again, a pioneer in thyroid surgery, has done a lot of seminal work in the evolution of thyroid surgery as we see it. So they concluded, and this is a current opinion paper, so it's a review, that the utility of IONM in reducing the rate of recurrent laryngeal nerve injury is controversial, but with the caveat, may be helpful in certain high-risk cases. So when we talk about high-risk cases, the three categories that come to mind are large goiters, recurrent cases, and cancer. But when we talk about cancer, there are a couple of things that we have to elucidate. Remember, I like saying this line, there is no high-risk surgery for a low-risk thyroid cancer. The way you do surgery for a low-risk thyroid cancer, which would probably be about 30 to 40% of all of our practices, is just the way like you would do a routine thyroidectomy or a routine hemithyroidectomy. So all thyroid cancer does not or should not necessarily constitute a high-risk surgery. This is a systematic review and meta-analysis, and the indications that they elucidated are on the left, and the paper at the bottom, the indications that they elucidated are on the right. And this pretty much indicates that, that yes, the role of surgery in Graves' disease is, of course, individual or institution specific. But essentially, we are dealing with a disease which has more thyroiditis, and therein you expect a lesser rate of nerve identification. But that, again, should not be followed as a norm. Whether or not it helps us in the other subsets is something we'll talk about. But for the most part, we'll leave our discussion as thyroid cancer based. So this paper said that even though they selected the categories of a high-risk thyroid surgery, the transient and the permanent recurrent laryngeal nerve palsy rates were similar between the monitored groups and the unmonitored groups. And just like the prior study with 20,000 nerves at risk, it said that the visual ID is still gold standard. So what else do we know? Another paper says visual ID is gold standard, and IONM does not decrease recurrent laryngeal injury compared with visualization alone. And remember, we are only talking about cancer from here on. And they said further evidence is needed. And this is a relatively recent paper, but there's been some more work that's been done since then. Another paper says that visual ID is gold standard and did not decrease rates of nerve injury. And another paper says that not just during thyroidectomy, even during central neck dissections, whether or not you do IONM would not make a difference. And permanent lesions are roughly the same. And incidence of nerve damage during thyroidectomy was higher than CND in monitored patients. Now that, again, would be the complacency issue that we talked about. So the papers that we quoted so far would indicate to you why are we discussing it during a webinar which is so relevant about thyroid disease per se. That is because there are some benefits of neuromonitoring in thyroid cancer as well. Let's try to lend some objectivity as to whether IONM actually results in recurrent laryngeal nerve safety or not. Because after RLN safety, we'll talk about the other techniques. But currently, we are only focusing on recurrent laryngeal nerve and thyroid cancer. Remember, there is an amplitude, and the resting amplitude is by intermittent stimulation of the recurrent laryngeal nerve through those electrodes. So if you have a baseline amplitude and it decreases less than 50%, and if you have, and once you have a decrease in 50% and you stop doing what you are or stop doing that part of the surgery, it is associated with a lesser incidence of abnormal vocal fold movement. So simple biomechanics, right? If you're irritating a nerve, let go, and you'll realize that you're irritating it less. Okay. Another paper would indicate that even if you were doing recurrent laryngeal nerve monitoring, this is again older data, says that it did not decrease the rate of vocal fold mobility in this subset. This is the Sao Paulo Medical Journal, and this is older literature. So we'll take that with a pinch of salt as we move forward from a high volume center, of course. The real importance of IONM and recurrent laryngeal nerve safety, in my opinion, lies in the ability to do stage surgery. So if you have a loss of signal once you are dissecting one side, or more than 50% decrease in amplitude, and if you're not operating on a patient who's high risk thyroid cancer, you might consider staging the surgery. The philosophy sounds very attractive because you don't really want bilateral laryngeal nerve palsy. However, what the study at the bottom showed us is that there was a 90% chance of signal recovery intraoperatively, and the mean time to recovery was 20 minutes. What that means is, again, a very attractive hypothesis that if you are able to have your signal recover in 20 minutes, you would typically have only 20% of nerves which would have transient dysfunction. But transient dysfunction would also not be acceptable on one side, because if you have transient dysfunction in the postoperative setting, and if the other nerve has the same tonotopic distribution as the first one, which it is likely to have, you don't want to end up with a bilateral RLNP. So for a patient who has very aggressive disease, who has potential bilateral recurrent laryngeal nerve invasion, and where you have loss of signal while dissecting along a nerve, it might sound as making sense that you don't do the opposite side and you stage it. You wait for the patient to wake up, you analyze how the first recurrent is, and then you make a call as to whether you have to take it up in the same setting or otherwise. That is something that can be done in up to intermediate risk thyroid cancer. But for high risk thyroid cancer, you don't really want to go in again. And there are some more objective criteria that have been used to study this a little further. Remember that these findings have low specificity, and just like the prior paper that we quoted, even if the patient had a transient recurrent laryngeal nerve palsy and had regaining of loss of signal, if something happened in those 20% of cases, the majority regained function at 3 to 12 weeks. So it's level 2B evidence based on this study, and this is a laryngoscope study from 2013, which said that you can use intraoperative nerve monitoring, again, in thyroid and parathyroid surgery in general. There are other high-risk subsets also, which may benefit from staging following a loss of signal. Remember that the data on this is very controversial. Once you have a loss of EMG signal on one side, the surgical strategy on the other side has to be defined, as outlined by the first paper. You could either choose to stage it, like we've discussed, or you might choose to go ahead with the entire surgery and take the consequences as they come. Now, if you're using monitoring, it's of course a given that you're using it because loss of signal is probably the most important reason why you use intraoperative nerve monitoring for, and therein you might potentially end up compromising a patient, or in our country, make the patient less compliant because he or she would not show up for the second surgery. And that is something that we need to consider as well. We also know that indirect neurostimulation has been known to be more accurate than direct neurostimulation, and we'll talk about it a little bit. And it predicts late laryngeal function better. So all those patients who have recovery of loss of signal would probably be excluded. So if you could do some assessment in which you do indirect stimulation, not of the direct recurrent laryngeal nerve, that might be more reliable, and we'll talk about that. So to conclude, loss of signal has limited prognostic significance. The data is conflicting, and staging of surgery is the only potential benefit that we currently think a loss of signal on one side might have in patients that you planned a total thyroidectomy on. However, you have to rely on your own interpretation of literature and evidence to make sure that you're able to extrapolate it if you're using neuromonitoring in your setting. Remember that if you did monitored surgery, then you're also dealing with a situation. This study particularly deals with advanced thyroid cancers and staging the surgery in that. In this study, it's notable that most of the patients had extrathyroidal extension. This almost sounds like an Indian study, even though it came from North America. The vast majority had extrathyroidal extension. And you really, whether or not you can use stage surgery as a practice philosophy in our country with neuromonitoring, the feasibility in a lower compliance population with the resultant cost implications is something that we have to keep in mind. We don't really know whether it will be beneficial in the long run. So another meta-analysis, again, about 17,000 nerves at risk. What it shows is that for permanent recurrent laryngeal nerve palsy, there was no statistical benefit. There was a potential benefit for low residual thyroid. So in reoperations, they did not find any benefit. But if you had a low residual thyroid, there was a possibility, yes, that you could make the surgery more oncologically efficacious, which is a secondary indicator. That comes to mind. So the three things that come to mind from this paper and from the prior quoted literature is that does neuromonitoring make us more daring, so to speak, to be able to do a more complete cancer resection? Does it also help us in our ability to do thyroid reoperations? And is continuous IONM through indirect neurostimulation, like we talked about, is it the way to go in the future? Let's talk about oncological efficacy. In this paper, we know, and this is not a direct neuromonitoring paper, but it's that completeness of thyroidectomy was a surrogate for nerve identification. So the nerve has to be identified regardless. Oncological efficacy should not be used as a reason for you to use nerve monitoring. Nerve monitoring and the indications thereof would be dictated by other factors altogether. And if you have an experienced operator, then in that case, you would probably not really benefit that much from neuromonitoring as otherwise. This paper indicated that for a low volume endocrine surgeon, you probably might want to consider the routine application of IONM, which I also think is a very disturbing trend. Normally, most centers that use IONM are high volume centers. And of course, we all know the medical legal implications. We're only talking literature here. Of course, we can talk about medical legal in Q&A, but it would be incorrect to assume that a low volume endocrine surgeon will be benefited a little more if he has neuromonitoring. That situation would be very different from, let's say, a program director in a fellowship taking a fellow through a surgery. That would be different because you have the requisite number of years of experience, even if the fellow is the primary operative surgeon. Let's talk about reoperations. Remember that these studies are limited, as you would imagine. The numbers are very small, so it's difficult to draw any meaningful conclusions from this. But what we know is that if you have a patient who's been operated outside and has gross residual disease in the thyroid bed, the use or the confidence imparted from IONM might be able to enable early reoperation. Because there was an improvement in transient recurrent laryngeal nerve palsy vis-a-vis the number of days from the surgery in a few studies, as have been quoted over here. However, if you look at it long term, there's no difference in permanent palsy rates. There's no reduction due to unintentional injuries. So essentially, the recurrent laryngeal nerve palsy difference was only secondary to the fact that the nerve was invaded per se. So routine utilization was not recommended based on these studies. And we talked about continuous IONM, just to let you know. Continuous IONM is when we do not use the endotracheal tube with the electrodes, but we actually put an electrode on the vagus, and it gives you a continuous small pulse of amplitude. There are benefits advocated for that, but we leave it to the Q&A also. Having said that, there is data emerging now, even on CIONM, and it shows that there's no statistically significant differences. Remember, it's also been used for the EBSLN. Yesterday, someone asked me a question about a professional voice user and our philosophy on EBSLN. So my answer to you would be that just to be on the safer side, if you're dealing with a professional voice user and you do have the benefit of not just having a nerve monitor, but also a fair bit of experience on it, by all means, use it in that. It has also been used in conjunction with a robot, but again, there are cost implications, and we'll quickly flip through this. And there are other caveats as well, and these are anecdotal. So again, some points to take home. So finally, after judging literature for what it's worth, when and why do you use the intraoperative nerve monitor in thyroid cancer? I advocate the middle path. There is questionable benefit in transient recurrent laryngeal nerve palsy. The completeness of resection is something which we don't believe the IONM should be used for, because it's usually a function of operator experience. So an experienced operator would do as complete a resection whether or not he has the nerve monitor or not. Remember, we are talking about the per primum setting. We're not talking about recurrent disease setting. There is applicability in multiple patient subsets like large thyroids, like reoperations, and like in large volume thyroid cancer, but we don't know the exact benefit. There are cost and resource implications. So by all means, and this would be a statement I'd probably make for the robot as well, if you have access to this technology, by all means, train in it and then use it. But currently, as far as INM is concerned, whatever systematic reviews and meta-analysis we have, they suggest a non-universal approach. So don't use it in every case of thyroid cancer. And remember, like I said earlier, a high-risk thyroid surgery does not apply to a low-risk thyroid cancer. So low-risk thyroid cancer is actually a routine thyroid surgery. And after due application or emphasis to all the principles of thyroid surgery, you'll be able to do any surgery fairly safely, and we have to wait for higher quality data. This concludes the two recent advances that we wanted to cover, Bhargav. And I think that the bottom line, of course, would be select the indicated subsets of patients for application of remote access surgery, as well as the patients that you want to do nerve monitoring on. If you have the expertise or the benefit of having them at your institution, by all means, go ahead and train in it first. Evaluate all the available literature and extrapolate your evidence to what patients you're going to use it on. But by no means should you haphazardly apply the technology to every patient who walks in the door simply because he or she could benefit or could be a candidate for that technology. That would be my take home to you. Thank you.
Thank you, sir. That was an excellent lecture. Sir, there have been questions pouring in from the previous topic also, so I'll go through all of them.
Sure.
So, a question from Dr. Naveen. He's actually from Kathmandu. So, his question is: how long does the thyroid suppression can be continued for PAP-CA with neck metastasis following total thyroidectomy and neck dissection, as we cannot do radioablation in Kathmandu because of the current situation?
That's a very good question, and we talked about the fact that resource availability is very important in our subcontinent. So I congratulate you, Dr. Naveen, for asking that question because it's very relevant. It's equally relevant to India and Nepal. I would advise you to stratify these patients first. If this is a patient who's low to intermediate risk and is an excellent responder, not just on radioactive iodine scanning, but on your biochemical indicators, by all means, you can continue following up the patient in Kathmandu. However, if it is a high-risk patient and you are concerned in the short-term disease follow-up period that there might be microscopic residual, because remember, the best of surgeons could have microscopic residual in high-risk thyroid cancer. Make sure your stratification is complete, whether initial or otherwise. And for high-risk patients, I would recommend setting yourselves up maybe with an Indian institution which can provide high-dose radioactive iodine ablation or radioactive iodine ablation across the board to your patients. But it's a surprise to me. Does Nepal not have an ablation institution at all? Yeah, did you? Yeah, so I hope I answered that question. I was just curious to know whether Nepal does not have any iodine ablation, but the answer is for high-risk thyroid cancer, you want to set yourself up with an ablation institution. For low to intermediate risk with excellent response, you might be comfortable just following them without radioactive iodine.
Okay, sir. I'll follow up with that answer in the chat. So going to the next question by Dr. Kavita. How much increase of time is required in case of superior nerve dissection? And what is the dissection by a robot as well as the risk of superior nerve dissection in case of robot? All these questions came during time of the videos during robotic neck dissection.
Yeah, so if I understand the question correctly, we had signal loss for some time in between. But if I understand it correctly, how much time does it take in a robotic thyroidectomy compared to open? Is that the question?
Yeah, yes, sir. And the risk of superior nerve damage, superior area.
So I'll answer the first part first. Any institution that does remote access thyroidectomy on a routine basis, there is a very steep curve in the decrease in duration of the surgery. So for most centers, including ours, the first couple of thyroidectomies would take as much as about 4 hours each. Having said that, as head and neck surgeons, compared to, let's say, endocrine surgeons, we are more comfortable with the neck anatomy, more so with the retroauricular approach. So currently, retroauricular robot-assisted hemithyroidectomy in our center will take about 2 hours. Having said that, it also depends on how experienced a proponent you are. We've done much less than 100 so far. There are some centers in South India, especially, who've done a little bit more than that. But if you look at the ones that have done thousands, notably the ones in Korea, having trained with them, I can vouch for the trans-axillary approach that Professor Chung does. His robotic on time was about 20 to 25 minutes per case for a hemithyroidectomy. So it's just a function of operator experience, just like any other surgery. Regarding your concern about the superior laryngeal nerve in a robotic thyroidectomy, with the retroauricular approach, it's actually perfectly safe. In fact, we end up identifying the superior laryngeal nerve every single time we do a retroauricular robot-assisted thyroidectomy because it's right in the way. One of the first things that you see is the cricothyroid and the cranial border of the same when you're doing the robotic part of the dissection. So for the most part, it will be very safe. Dissection would not be required over there. But also remember that there is a selection bias to those robotic patients. You, or at least us in our practice, would not consider robotic surgery for any cancer that could be potentially aerodigestive tract invasive. So that's a concern every single time. However, the more experienced proponents, like the Koreans that I talked about, would consider it even for grade 1 invasive cancer. So there's a lot of variability here. But for the most part, the superior laryngeal nerve is going to be safe by the retroauricular approach. Transaxillary, you don't identify it every single time, but we've done more retroauricular, and I assure you, it's safe all of the time because we see it directly.
Okay, thank you, sir. There is a reply from Dr. Naveen from Nepal. So they do have REI there, but because the current situation, they were not able to refer him to the specific center, I guess.
Oh, the current situation prevailing in view of the lockdown?
Lockdown, yeah.
It's an irony so far that your great initiative is in the tune or in the face of the lockdown. So I wanted to wish good health to all of the participants who are here and all of the participants who were there yesterday also through you, Bhargav. But this is a situation that's a problem. BRIT, which is the Indian authority, and I'll want to assure Naveen on this also, has not been issuing radioactive iodine outside of an institutional setting. So private hospital like ours has had its own trouble doing it. But in India or pretty much in the subcontinent, we always have to innovate. So our high-risk thyroid cancers, which take more time to raise their TSH, have not been started on levothyroxine. But I will admit this: at least 10 or 15 patients of ours who are awaiting routine scans have been restarted on their eltroxin simply because they were developing intolerable side effects because of the duration of the lockdown. But I'm glad that your center has the option, and I wish you all the best. Just make sure you stratify all your patients.
Our next question is by Dr. Yoshna. She's asking to kindly brief the RAI in case of metastatic DTC post total thyroid.
Okay.
Or after, if they develop metastasis after the thyroidectomy.
Yeah. So we talked a little bit about those, but I'll keep it very simple, Jyotsna. If you have disease remnant in the thyroid bed that is scintigraphic, but as a surgeon, you are fairly confident about the completeness of resection. In high-risk thyroid cancer, most of your nuclear medicine physicians, after discussion in tumor board, will offer between 70 and 110 millicuries. If you have distant metastasis, and I'm using the first example as a surrogate to answer your entire question, if you have distant metastasis in the lungs, typically the minimum dose that will be given will be 150 millicuries. And they might take it up to 200 millicuries depending upon whether they are empiric or dosimetric with their dosing pattern. If you have bone metastasis, then in that case, the minimum dose that is typically used is about 200 millicuries. And recurrent doses, of course, depend upon the extent of avidity that your tumor shows you. But initial dosing, this is a brief algorithm that we have in our tumor board that we discuss every single time a patient like this comes in.
Sure, thank you, sir. Again, the same question by Dr. Joshna. Which intraoperative challenges would you force to change from robotic to open surgery?
That's a great question. And the key to robotic surgery that is successful is appropriate case selection. We had a slide which indicated how we select our cases. You need to look at the patient's BMI. You need to look at neck and axillary dimensions. You need to look at nodule size and a few other criteria to help you decide, including surgeon familiarity, what approach you're going to use. So far, we've only had one patient that we started off with a transaxillary approach and we converted it to an open thyroidectomy. And remember, it's not a very pleasant situation. Every single time that you do a remote access thyroid surgery, you have to consent the patient like we have been doing, like every other institution have been doing, that, based on the extent of the disease, you might have to convert. The reason we had to convert in this particular patient was because we saw extensive sterno-hyoid involvement, and we already knew that the patient was a Bethesda 6. In this case, I felt more comfortable that there might be caking in the area of the trachea and the ligament of Berry, and it was a young patient with intermediate risk tumor. So we felt it was safe to just do a 6 centimeter incision in the midline and go ahead with it. Your counseling has to essentially include that. But the key to avoiding this scenario is careful selection.
Thank you, sir. There is a next question by Dr. Kavita, which I'm not able to completely understand, but I think what she wants to ask is, can you elaborate the use of harmonic scalpel in thyroid disease?
Sure. So we use the harmonic scalpel in a robotic setting. And yesterday during our videos, we might have shown you the harmonic focus or the focus plus 9 centimeter instrument. Remember that the harmonic instrument is a good tool, but at the end of the day, it's an energy device. The broad action that I'd give you is you need one energy device, be it a good bipolar, be it harmonic. Some people use, and we use it often as well. We use the LigaShow 10 centimeter also. We are lucky to have all of these in our institution. But when you talk about harmonic technology, remember 2 or 3 things in addition to what you do with a bipolar. Remember that the harmonic has an insulated blade and there is an energy blade. So you always try to keep the energy blade on top under direct vision so that there is no unanticipated thermal damage. Number 2, when you're working around nerves, keep a distance of about 3 to 5 millimeters, like we spoke about earlier, to make sure that there is no penumbra of thermal damage that might end up causing transient thermal neuropraxia of your nerves. Number 3, the harmonic is something which takes some getting used to. So I'm only talking about open harmonic right now. Once you have figured it out how to use it without wasting any time, there is also some cost involved. Remember that on paper, the hand pieces are disposable, even though most of us end up reusing them. And the energy source of the harmonic also has 100 uses. So there is a definite cost that's going to be applied every single time. My advice to you would be use the harmonic in extended resections where you think that the duration of the surgery would be enough for you to actually do a cost saving by eventually using the harmonic, as opposed to using it in a half an hour hemithyroidectomy. It does not offer too much.
Next question is an interesting question by Dr. Vinayak. I think he's asking about the use of robotic in neck disease, neck dissection.
Yeah, we are strong proponents of not doing a robotic neck dissection for squamous cell cancer. I think the implications, the prognosis, and the anticipation of a patient is very different compared to thyroid cancer. The only neck dissections that we've done robotically are the ones that were associated along with thyroid cancer, and that makes sense. A lot of time with your mucosal resections for head and neck cancer, I know it's outside of the purview of this, but I will tell you because we need to probably bring out a more sensible mindset in this. A lot of the times you'll end up doing some reconstruction also, and then you'll have to take it a little bit further by doing the specialized instruments for microvascular surgery that are also robot mounted and not used in India. I used them during my fellowship training in Michigan in 2010, just before I finished. And very recently, I used them at the Intuitive headquarters in Sunnyvale. But the problem is that you're now adding further and further cost. So only use the robot for neck dissection if it really has any potential benefit in terms of cosmetic or subjective scar satisfaction in patients with good prognosis disease. We don't use it for squamous cell cancer, but also I don't hold anything against the people who use it for robotic neck dissection in squamous, simply because we don't get the kind of patient populace. We don't get the kind of patient populace who would ask for it, and we don't deliberately push the technology. So even despite advocating robotic thyroidectomy in the indicated subset of patients, our robotic to open thyroidectomy rate is still 1:8. So only 12% of the thyroidectomies that we've been doing for the last 1 year have been robotic. So just make sure sensibly apply the technology that you have available.
Yeah. So the next question is by Dr. Rajan Shetty. As USG is not that sensitive in detecting the central compartment nodes, what if we encounter the central compartment nodes during robotic surgery, and we could need a total thyroid with at least central compartment clearance? So how do you go about that?
Yeah. So actually, let me add to what I said the last time. The need for a neck dissection is not a contraindication for using robotic surgery, first of all. If you are committed to giving a scar result or a subjective satisfaction result to the patient, the presence or absence of nodal disease will not actually make a difference. So, if I had central compartment nodes that are not very large, that are not invading any of the aerodigestive structures or the recurrent laryngeal nerve, I would still counsel that patient for robotic surgery if I were confident I was able to remove it correctly. Now, it is our institutional philosophy that we talked about yesterday that for T3 and T4 disease, we do some cross-sectional imaging, especially in papillary thyroid cancer, Bethesda 6 disease, in which we are able to pick up whether or not there are any central compartment nodes. That really helps you elucidate the disease process per se. If you've picked up central compartment nodes inadvertently, that would mean that with the application of our algorithm, there will be small volume nodes, which can be very well addressed robotically. So there's no indication to go open with that. So you can do a central compartment dissection equally well robotically. In fact, you get a better view. And if you get a chance to work at the robot in your institution, if your institution has one, or if you get a chance to attend a robotic test drive, you'll realize the magnified three-dimensional stereoscopic view that you have, and you're actually able to identify the parathyroids a little better than you would otherwise with an unmagnified view. So yes, you can do a central compartment dissection very easily with a robot.
Okay, sir. Next question is by Dr. Sujan. He has asked multiple questions, so I'll go one by one. So, with a smaller incision remote access thyroid surgery, do you prefer gas or do you prefer gasless surgery?
So we moved away from this now with the robot, but at the time that we were doing a transaxillary non-robotic, we were doing gasless, and the large part was that we were anticipating that we would be acquiring robotic technology. So we did the 6 centimeter tunnel like we do in a robotic surgery, the anterior axillary fold incision, and we used to go gasless over there. But yes, if you're doing the Baba approach or if you're just using laparoscopic ports, in that case, the gas thyroidectomy would be something used. But my experience is only with the gasless approaches, largely because we were preparing ourselves for robotic. Remember that the techniques that are pointed out, retroauricular is a gasless technique, and the transaxillary, at least the transaxillary that we use, the single incision transaxillary, is also a gasless technique because you have to create a tunnel as you go up.
Okay, sir. So in continuity with the earlier question, any precautions to be taken and chance of ventricular tachyarrhythmias?
Ventricular tachyarrhythmias?
Yeah.
During?
During the surgery.
During
in continuation of the earlier question.
So not specific to robotic surgery. I would have thought that your question would have entailed surgery for thyrotoxicosis per se, which is a relative contraindication for robotic surgery. But no increased incidence of ventricular tachyarrhythmias from robotic surgery. But robotic thyroid surgery has its own unique or anecdotal complications. There have been reports of tracheal injury because you don't get the tactile perception from a robot. So I would say it would probably be a factor of enthusiasm or poor case selection that any tracheal injury would happen. The chest wall anesthesia is sometimes a problem. People get chest wall paresthesias with the transaxillary approach, which has actually helped us move a little bit more towards the retroauricular approach. The retroauricular tunnel or the transaxillary tunnel will have anesthesia for about 6 to 12 months, as you would anticipate in any kind of neck surgery. So those would be the typical things that you encounter more than that. So actually, a great line that I always, and I borrowed it from one of our professors, is that, it's not really minimally invasive surgery. Robotic thyroid surgery actually adds an invasive component, but the end point is largely cosmetic and subjective. So if your patients have a high rate of scar satisfaction subjectiveness, yesterday we alluded to a study during our parathyroid preservation talk where subjective rates of scar satisfaction were already in the 90s. So you might argue that why would you go ahead and try to make it 100 and therein put in the cost and implications of a robot? That's why we got the subsidy in. That's why we did our feasibility analysis till all the participating departments in our institution really thought that we could kick in with this. But yes, apply it sensibly in the indicated subsets.
Okay, sir. The same Dr. Sujan's question. I couldn't understand completely, but I think what he's asking is, in your experience, what should a beginner start with, robotics or minimal access surgery?
So we, by if you mean MIVAT, minimally invasive video assisted thyroidectomy as minimal access surgery, I will answer this based on the experience that I've had. See, the transaxillary gasless I already told you about. We just did a few cases. I'll tell you my experience with the MIVAT because we used to use the Mikoli thyroidectomy with a 2 centimeter incision in Michigan during my fellowship. And most people have given up on the Mikoli thyroidectomy. It's a little fiddly. We can remove a thyroid in a 4 centimeter incision most of the time as long as the thyroid is not abnormally enlarged. Our cutoff for size of incision is actually the maximum craniocaudal dimension of the thyroid lobe. So if craniocaudally the thyroid lobe measures 4 centimeter, then the incision is 4 centimeter and nothing more than that. We don't really think that putting a scar which is 2 centimeter lesser is going to add to any increased scar satisfaction. So yes, the Mikoli thyroidectomy or the MIVAT is completely out, especially if you have the robot or other methods of remote access surgery. But yes, if you have to do like we did over a period of a year or two, if you think that you will get true remote access surgery at our institution in the near future, then you go in, start making your incisions smaller without compromising your efficacy or completeness of resection. You could do something called the subclavius approach, which especially in the conservative mindset who don't really want to wear very low neckline wear, especially females, you could do the subclavius approach and then move a little bit more towards the axilla and see how you do. See if your current instrumentation, your technology, your anesthesia, your armamentarium, your assistants are geared up to developing a remote access thyroid surgery program. That's what I would recommend. But yes, MIVAT, most people don't use it these days.
So next question is a little interesting question. The biochemical incomplete response is defined as thyroglobulin elevated with no structural or functional evidence of the disease. So how is it different from tennis, and how is it, what is to be managed?
So that's a great question. You know, tennis came about as an attractive analogy at the time that DRS was still did not have widespread applicability. And it's important for us to realize that stratification of the disease and dynamic risk stratification is really that will help you compare apples and oranges in terms of the way we see our tumors. So tennis is something I would not encourage you to follow blindly. You look at your thyroglobulin threshold the way it should be or the way it has behaved over time, and therein you take a call as to whether you are dealing with a disease process that might actually be there. For instance, if you have, let's say you had a serial thyroglobulin around 2 and you suddenly go supra threshold and you go to about 2.5, that in my opinion would not be an indication to actively survey the disease at that point of time. If the disease was low to intermediate risk to begin with, at that time you might feel okay with just reducing the interval of follow-up investigations and taking a call. What we do very often in these patients is we keep them on higher hormone withdrawal for a couple of more weeks, considering they don't have a history of severe symptoms, and then retesting. A thyroglobulin that shows a downtrend after 2 or 3 weeks with stable antithyroglobulin antibodies is usually reassuring. And in that case, you don't really have to investigate them any further. So don't go with the limited tenets of a tennis syndrome. Look at the threshold of thyroglobulin that you're comfortable with regard to the risk that your disease currently bears, and then take a final call.
Okay, sir. So our next question is again by Dr. Joshna in continuation with the earlier topic. So how long is it safe enough to delay the RAI for recurrent DTC post-surgery in this COVID situation?
Yeah, that's a good question.
Inavailability of iodine and thyrogen in HCG.
Yeah, and that's a good question. I'm glad someone asked that. In fact, there's another extension to that question about the use of CT and iodinated contrast, but we'll address that later. We'll first get to the question that was asked. With regard to the COVID situation or without, you are generally safe keeping a patient without radioactive iodine ablation for a maximum period of 6 to 8 weeks. Now, in high-risk thyroid cancer, you're also concerned about another factor, that you're letting the TSH rise. If you're letting the TSH rise to a level that it might end up being trophic to DTC, it would be a problem. So our cutoff is usually at most about 8 weeks. You also can employ certain tools that you have, including repeat scintigraphy for disease, assuming sometimes availability of radioactive iodine would be to the extent that only small quanta would be released to your institution one time. So you might have a scanning dose, but you might not have an ablation dose. That happens very often in institutions in the private sector. I work in an institution like that where you might not have an ablation dose immediately available. Remember that whenever you planned as the optimal date for radioactive iodine ablation, you'd be okay delaying it by at most 2 to 3 weeks and not beyond that. The question of iodinated contrast and whether or not it would have a role has already been answered. There are a couple of papers, a JAMA paper notably, which says that you measure the urinary iodine creatinine ratio, but even that is not required these days. You know that the doses that are used in iodinated contrast will typically be able to be washed off within 4 weeks. So yes, you can do a radioactive iodine uptake scan within 4 to 6 weeks of administering an iodine contrast dose. What we do in addition is we have a separate protocol for a central compartment CT. So a patient only gets about 50 ml of Omnipaque as opposed to the usual 75 to 100 ml of Omnipaque. Therein, the cumulative dose of iodine in the body is less.
So our next question is an interesting question by Dr. Nisha Singh. What to do for RLL reanastomosis intraoperatively in two situations? One is complete transection or one is partially injured and partially transected.
Okay. So, yesterday someone wanted us to address RLN injury, and I'm glad someone asked the question to remind us of that. So, divide your RLN injury into unanticipated and anticipated resection. Okay. If it is an unanticipated injury and you've picked it up only later on, and we're talking about non-nerve monitored patients, if you have greater than 40% nerve fiber integrity, in that case, you're fairly certain that you will be able to maintain tone of the vocal cord. Everything is going to depend on the tonotopic distribution of nerve fibers within the recurrent laryngeal nerve, which currently no investigation is able to predict. So if you have a transection of a few fibers, and there is no thermal damage that is widespread, which means you've not bipolar the nerve or something. In that case, you would be okay with letting it be and giving it a chance to heal, knowing that you will probably be okay that way. And of course, if you have a nerve monitor, it might be a good idea to bring it in at that point of time. If you have a complete unplanned transection without thermal damage, you freshen the edges, and a lot of times you'll be able to do a direct neurorrhaphy. Sometimes you might not be able to do it. In that case, you do what Miyachi has advocated and worked very elegantly on that. You work on the distal stump of the recurrent laryngeal nerve, follow it. Sometimes you might need to follow it inside the cricothyroid joint, get a good stump and do an answer to recurrent laryngeal nerve anastomosis if the distance is too much. That philosophy you can also use in planned recurrent laryngeal nerve resections. If your segment of recurrent laryngeal nerve is not identifiable inferiorly, that is pretty much the only option that I would recommend you do. Otherwise, nerve grafting is an option, but for the most part, the results that you get from an ANSA recurrent anastomosis are fairly good.
Thank you, sir. So next question is a very clinically relevant question, sir, by Dr. Singh. The threshold tumor volume above which you will go for surgical clearance in previously operated field, RAI versus surgery.
Sure. So good question. Normally we know that radioactive iodine ablation will be able to treat or remnant ablate up to 3 to 4 centimeter cube. Or if you look at the density as 1 of the thyroid, then 3 to 4 gram of thyroid tissue. Now, that does not mean that we advocate near total thyroidectomy. Why? Because you know that there might be microscopic disease outside of the thyroid bed that you might also have to take care of. So I would advise you to take this decision after your diagnostic whole body iodine scan. Once your diagnostic scan shows that the only disease that is residual is in the thyroid bed, in that case, you could take a judgment call by doing an MR. We usually do an MR in this circumstance to actually quantify the volume of disease that is showing signal enhancement and is not a hematoma or something else, which a CT might erroneously pick up. If your total volume is 3 to 4 centimeters cube or lower, and if you are not comfortable visiting the thyroid bed, let's say there's a lot of fibrosis, scarring and everything, you might be okay giving the patient radioactive iodine ablation. But normally that would not be a low dose. The minimum that would be required in that circumstance, based on my understanding of literature, is about 70 to 90 millicuries, and that's a minimum. Having said that, our philosophy generally is to look at the patient individually, see if the extent of fibrosis, and the MR helps you assess that as well. We would normally go in if you have about 3 to 4 grams residual. So only the scintigraphic uptake with no anatomical residual would be our indication for giving the patient radioactive iodine for remnant ablation. In most cases with demonstrable residual, we know that the local recurrence rates are going to be decreased if we address it surgically. So a lot of our patients will go for repeat surgery. And if you were there at the time we presented the video today, you know how to define the safe limits of reduced central incontinence surgery.
Okay, sir. Next question is by Dr. Abhimanyu. Would you do opinion? What is your opinion on pre-ablation and the post-ablation REI scan routinely? Would you do?
So a pre-ablation scan is something which actually has prognostic significance and also helps us decide the follow-up protocol. So pre-ablation scan is routinely done at our institution. Regarding post-ablation scan, I believe we covered it in the talk and I'll repeat it right now. Some proponents argue that if you're going to give low-dose iodine, it doesn't really matter whether or not you do a post-ablation scan. But my recommendation to you would be that for all high-risk thyroid cancer, you obtain a post-ablation scan also. That will help you know that in a disease that has as much variegation and heterogeneity as thyroid cancer, whether or not your meds are avid. A lot of the times your thyroid bed might or might not be avid, but the meds might be avid. And therein, you might be able to take the call with the systemic therapy options available, that whether or not you want to do polytherapy for that patient. In addition to radioactive iodine, whether you want to add something else to the treatment. If the patient, for instance, if you don't do a post-therapy scan in high-risk thyroid cancer, which may potentially be metastatic, the caveat would be that you might be missing out on disease which actually did not go to the Met simply because you had a lot of loco-regional residual remaining anyway, and you might be depriving that patient of the systemic therapy options that he or she could have benefited from for the 6-month odd period that you will be waiting now. So for high-risk disease, always insist on a post-ablation residual. For low risk, it doesn't really have much of an implication, so you let your nuclear medicine doctors decide. With regard to pre-ablation, we use it routinely because we are proponents of initial as well as dynamic risk stratification.
Okay, sir. Our next question is by Dr. Ramandeep Kaur. What is the success rate of recurrent laryngeal nerve anastomosis?
So it's a good question. The most you'll be able to restore for the initial part is tone, and the least you'll be able to achieve is the tensile strength of the cord. Now, the tensile strength, in addition to the cricothyroid, is also contributed by other muscles which are supplied directly by the recurrent laryngeal nerve. If you do a primary neurorrhaphy versus doing an interposition graft, that will also have a role because the axon count of whatever graft you use cannot be exactly matched to the axon count of the recurrent laryngeal nerve. Having said that, there are instances, if you do a recurrent laryngeal nerve anastomosis, you will be able to get good mobility as well. But usually what you're aiming for is a less phonatory gap and a position that you'll be over. But remember one thing, even if you have to take the recurrent laryngeal nerve, you typically don't do a thyroplasty in the same setting. And the reason for that is because the tonotopic distribution of the nerve is going to eventually decide what the eventual position of your weakened cord is going to be. Success rates are usually to the tune of 40 to 70% in terms of attaining full mobility, and about 70 to 90% in terms of attaining tone, to the extent of the patient having minimal symptoms and no aspiration.
The next question is also by Dr. Ramandeep. Any preoperative factors to decide for transaxillary versus retroauricular approach?
Yeah, I think we lost signal for a second. So was the question deciding between retroauricular and transaxillary?
Yes, sir. I think there is a small mishap between happened. Lost all the questions. Anyway, I remember the question. What is the difference between transaxillary and retroauricular approach? What is the preoperative factors that you see?
Okay, so
before you answer, just the last 3-4 questions I have lost because of some technical glitch here. I think because of that, is lost.
You can ask the people to resend it to you. So that you will be in a
situation. To ask everyone, kindly resend your last 3-4 questions to me, please.
Okay. So, to answer Ramandeep's question and also to probably talk a little bit more because this question was shared initially also. Let's move to the point where we talked about postulating. Remember, we don't claim to be authorities on this, but this is something which comes up very often. So this is the slide. Can you guys all see it?
Yes, sir. We are able to see it.
Yeah. So when you select between retroauricular and transaxillary, the nodule size is open to debate. The location in superior nodules, you'd probably think it's counterintuitive to select retroauricular for inferior transaxillary. If you're going to do a concomitant neck dissection, I think most head and neck surgeons would typically prefer the retroauricular approach. Neck and axillary dimensions, we are trying to do across 3 institutions some kind of data comparison to see how neck dimensions, the presence of a short, stocky neck, the thyromental distance and everything is going to play a role. But that's data that's unfortunately not been generated anywhere so far, including the worldwide proponents, because unfortunately the proponents of robotic thyroid surgery only did one approach. They never really did a head-to-head comparison like we talked about. BMI, we've talked about, like we mentioned earlier also. And if you have a tendency for scar alopecia, remember the retroauricular scar might still be faintly visible. So in that case, you want to go transaxillary. But at the end of the day, all that matters is surgeon familiarity. Whatever you feel comfortable with and whatever you have trained in is something that will eventually end up deciding your approach. Remember that robotic thyroidectomy, for the most part, is going to be indicated in relatively younger, cosmetically conscious people with or without a tendency for hypertrophic scar.
Okay. So, next question is, do we always need to do REA scans in low risk patients to decide for REA ablation? If no, then how do we decide that?
Yeah, so we talked about this for low and very low risk thyroid cancer. What you and certain categories of intermediate risk also, like we showed in the case vignette at the beginning of our first presentation. What we end up doing is we do a stimulated thyroglobulin at 3 weeks, assuming that the TSH was not suppressed or the patient did not have any hyperthyroid state. In about 80% of patients, in our opinion, you'll be able to stimulate the TSH to beyond 30. You do a stimulated thyroglobulin, and if it's a low risk patient and the stimulated thyroglobulin is less than 1, you would be well within your rights. And of course, you need to have surgeon confidence as for completeness of resection, especially if you did the surgery. It would be perfectly fine in the absence of raised antithyroglobulin antibodies to follow the patient with serial thyroglobulins as well as 6-monthly ultrasounds. In this case, you suppress the patient to the lower limit of normal. And normally the dose that we have found as a useful empirical dose will be 1.9 microgram per kilogram body weight in low risk thyroid cancer. That would be able to keep the TSH at roughly the same level. Test the TSH at 6 weeks and then titrate your dose accordingly. So by the time you do your 6-monthly scan, your TSH should be relatively stable. So in this philosophy, you can avoid the radioactive iodines.
Okay, sir. Next question is by Dr. Hitesh Patel. Sir, what surgery you prefer when one side whole lobe nodule and the other side tiny nodule of 3 to 5 mm is present? You do which kind of a surgery? Semi-total, near
Yeah.
total? Or?
So is this, but do we have the Bethesda stage on that? Is it
No,
proven
sir,
papillary?
he hasn't given any of those mentioned.
Okay, so we'll tell him about both scenarios. If it's proven papillary on one side, we talked about it yesterday also. In contralateral nodules, you have to do a total thyroidectomy because there's no way you can predict whether the other node has how much metastatic potential it has. Yes, steroids will help a little bit, but after a detailed discussion of the family, unless the patient is absolutely not fine with thyroid hormone supplementation lifelong, for the most part in contralateral nodules from ipsilateral papillary, you will end up doing a total thyroidectomy. Some exceptions of just doing hemi. If you're talking about multinodular goiter and Bethesda 2 disease, we talked about that in our nodule presentation also. Every nodule has an independent risk of malignancy, but if it is TIRADS 3 or lower, you can safely observe those nodules. You see what the independent metastatic or compressive potential the nodule has. And if your ipsilateral nodule is concerning, you do a hemithyroidectomy. If contralateral is concerning as well, then you do a total. If none are concerning, you might choose to observe them also. It's not a sine qua non that for every 2 centimeter nodule, you have to do a hemithyroidectomy also. You might want to observe a significant subset of these patients depending upon their radiological and cytological characteristics.
Okay, sir. So the next question is, kindly enlighten your experience in superior laryngeal nerve palsy and the measures needed to be taken intra or post-op management of it.
Okay. So there are multiple classifications, anatomical classifications, largely driven from cadaver studies of the way the superior laryngeal nerve comes in relation to the superior pole of the thyroid. Most of you would be familiar with the Cernia classification, in which the majority would be within 1 centimeter of the superior border of the superior pole of the thyroid. Remember, cross clamping would not be, just like in most other thyroid questions, the answer lies in the prevention. So, we normally follow a philosophy of ad lib identification, which means that if the superior pole extends above the cranial border of the cricothyroid, we always identify the superior laryngeal nerve. Otherwise, we do ad lib identification. We'll only identify it if it is in the way of the operative field, otherwise not. We also use magnification routinely throughout the course of the thyroid surgery, not just during the recurrent laryngeal nerve identification, but also to do it. So again, it depends on your own philosophy whether or not you want to use magnification. Superior laryngeal nerve palsy, unfortunately, is something which will be troublesome to the frequent or the professional voice user, and the lack of tensile strength can be corrected in conjunction with a good laryngologist. Having said that, the results are variable, and it's not really a very rewarding surgery. So the answer to your question would be to prevent superior laryngeal nerve injury in the first place by knowing that there are anatomical variations in the EBSLN and being completely cognizant about that during the time of the thyroid surgery.
Okay, sir. I think this is the last question for our session. What is the opinion on removal of disease from esophagus? What precautions or safety measures do you take pre-operatively?
So, see, if you have invasive thyroid cancer that's indenting or invading the esophagus, the first thing you have to do is to rule out intraluminal esophageal invasion. For the most part, the disease is going to be caking of the esophagus without actual intraluminal invasion, because that's not what the pattern of thyroid cancer spread is like. If you have intraluminal spread of the esophagus, you want to be absolutely sure, first of all, about how
Yes, sir.
aggressive the disease process per se is. So if I had intraluminal esophageal disease, I'd make absolutely sure first whether it's not anaplastic or undifferentiated carcinoma that I'm treating. I will use a small coaxial shoot needle to do a core biopsy of the thyroid first. Okay. If it's anaplastic with esophageal invasion, you typically would not do surgery. Okay. So the only ones in which you'll do surgery are the ones which have differentiated, or let's say the favorable variants of poorly differentiated thyroid cancer that you're going to do surgery on. Once you are, the pattern of spread, like I talked about, is usually not going to be involving the mucosa per se, but at most it's going to be limited to the muscularis. So you might be able to do an extra mucosal clearance without really entering the esophagus or doing an esophagotomy. If you're doing an esophagotomy, you don't want to do an inadvertent esophagotomy. You want to do a planned esophagotomy, and most of the time, direct closure is possible. The recurrent laryngeal nerve has to be completely skeletonized, and we talked about it yesterday in case of esophageal invasion, so that you're completely far away from that. And you'll have to leave it stented with a nasogastric tube for at least a period of 1 to 2 weeks. So just like you would do in mucosal disease to allow the mucosa to heal. Sometimes you will need a patch. And on 3 occasions in the last 5 years, we've required to do a radial forearm free flap patch in invasive thyroid cancer, which required not just an esophagotomy, but an esophageal resection, which would not close primarily, or would close primarily with the resulting esophageal stenosis. So yes, be open to all the ideas that you have. The armamentarium is all there with you, but just keep those options in mind. A lot of the times you'll be able to get it out extramucosally. Remember, you don't have to be dogmatic about the 5 millimeter margin in thyroid cancer. As long as you can get a narrow margin R0 resection, you'll be okay, because that does have a survival benefit.
Sir, one clinically very good important question by Dr. Joshua. How do you manage a chyle leak of thoracic duct intraoperatively and postoperatively?
Okay, so
And can you add this thing on one point from my side is, in case you're not able to, if you re-explore and you're not able to find it, and there is a dissection going down into the thoracic inlet in the superior part, what would you do at that time?
Sure. So the first thing is again prevention of identification. So there's one thing, the prevention of the thoracic duct leak in the first place. Uh, you have to be careful in the medial level 4, especially at the junction of the subclavian vein and the internal jugular vein. And you have to identify all radicals heading in that direction, especially ones with a thin wall, especially ones that seem as valved connections, and then ligate independently each one of those while you're doing your neck dissection. If you find intraoperative leak, uh, at that time, you have to, the first attempt has to be to identify the radicals, make sure that your vagus and phrenic are completely out of the way, and you're able to find them. And usually, ligation with silk helps because it induces fibrosis by means of an inflammatory reaction. If that also does not work and there is diffuse chyle leak happening from all over, then you also want to make sure that you are able to control each of the radicals, and by for the most part, in about 90% of cases, you should be successful. Once you've controlled the chyle leak that is happening intraoperatively, you do maneuvers. Of course, you do the Valsalva, but one thing that's additionally beneficial is the pressure on the epigastrium, which puts pressure on the cisterna chyli. So the abdominal pressure maneuver is something that's utilized fairly often by a lot of institutions, and we do the same unless there's a contraindication to do that. We apply pressure on the epigastrium, and that increases pressure on the cisterna chyli, therein finding any latent radicals that you might have. After all these measures, very rarely will you still find a situation where you have a little bit of a leak, and at that time, you have two options. Either you could try some biomaterial like Tisseel, BioSeal, or any such measure and try it and rotate some muscle in the location. You might have SCM remaining. You might want to bring a pediculed muscle only flap. The other option you have is to ask your thoracic colleagues to do a mediastinoscopy and do a thoracic duct ligation, or you can sometimes ask your GI colleagues to do that. Fortunately, that scenario very rarely arises. I can't remember any instance in the last 5 or 6 years that we had to do that. But for the most part, intraoperatively, you will be controlled. After the surgery, you keep the patient on carotid precautions, and you make sure that with the carotid precautions, immobilization for a small time period, following your drain protocols very carefully. And remember that you don't really want a drain directly sucking on the area of, you might want to do an interposition gel form or something like that between the drain and that. We, at that time, we don't like to use the Romson's high pressure vacuum drains. We like to use the Jackson Pratt drains, which have adequate pressure for vacuum suction drainage, but not excessive. Let's say, and then of course you do your medium chain triglyceride diet and everything else that would work. If you have a low volume leak, you need to explore these patients very rarely indeed. There is a protocol of octreotide. SMS Jaipur wrote a nice paper on that. A lot of us use it, and we found it to be beneficial in some refractory leaks. In addition to that, you put the patient on an MCAT diet, maintain direct control with dietitians, maintain carotid precautions, and usually you'll find a downtrend. Supraclavicular pressure dressings and everything are not really too much of benefit, but yes, you could use them as long as it does not compromise the neck flaps that you would have raised during an extensive dissection. Coming to the point that Bhargav raised, now you have a refractory chyle leak that is not responding to all the measures that I mentioned, including medical octreotide and everything. You are going in and you are now exploring a chyle leak. Remember, at this time, finding a chyle leak is going to be next to impossible because everything is going to be a congealed mess of tissue over there. At that time, you want to now keep your thoracic and your GI persons, depending upon whoever has the expertise to do it, on standby so that they can do a mediastinoscopy guided or a transabdominal cisterna chyli or a thoracic duct ligation. That would be really beneficial because you don't really want a chylothorax and mediastinitis developing because that would be terrible. That's life threatening. If you don't have that expertise or if you don't have those colleagues and it's impossible for you to arrange senior colleagues also, the best method to do would be to use a biomaterial. We used to use BioSeal in the US. It has limited availability over here. Here you have the option of Tisseel. Remember, we don't want a hemostatic agent like FlowSeal. We want something that's going to cake that entire area and is going to form a biolayer. And we'd put let's say a pectoralis major muscle only. At that time, when you have to re-explore, don't use the SCM again because it will really not have the vascularity as it had at the time of the primary surgery.
Thank you, sir. So our last question is a little from the genius. So what is your view? What do you advocate total laryngectomy in an extensive TTC?
Simple answer, a non-functioning larynx or intraluminal laryngeal invasion would be the only two indications of total laryngectomy in thyroid cancer.
So that's it, sir. You have so many congratulatory messages, in fact, which I'm not able to tell you in between. So those are the end of the questions that we got for today.
Sure.
So,
Thank you, Bhargav. Why don't you do the closing comments, and then I have something to say to you and your colleagues who arranged this initiative.
so we are actually very thankful for you for giving us this presentation, sir, from me and Harsha from my side. And we're looking forward to many more to come. So you can go ahead, sir.
Yeah. So we are in a difficult phase, all of us. But as an organization, I happen to be part of the management of the hospital that I work in also. As an organization, we have taken all the precautions, and I'm sure your organizations have taken all the precautions for you to be able to continue oncology in a very sensible manner. Most of the surgical association guidelines talking about the specific subject that we've been talking about for 2 days advocate low risk thyroid cancer as being deferred and high risk cancer to be operated. But I'll go a step further and tell you that if compliance of your patients is an issue, a thyroidectomy is not an aerosol generating procedure. So just make sure that you stratify your patients very carefully, take the necessary precautions, because if you are safe yourself, only then can you treat thousands of patients that you will be treating during your lifetimes. Make sure that educational initiatives like Bhargav's initiative and Sriharsha's initiative are well respected from Deepak and from the other people who contributed to this initiative. I really hope that the academic discourse that we had during the course of these 2 days was something that all of you found beneficial. And I learned a lot, and it was interesting. I was always on the lookout or the guard to hear a difficult question from a mind that is younger than mine and should be much better than mine as well. So thank you so much for the opportunity, and I look forward to being associated with you as an attendee as well, not just as a faculty and as a speaker.